Schizophrenia. 20 symptoms and treatments of this mental illness. Written by Albert Rogers. Narrated by Matthias J. Introduction. I personally know some people in my immediate circles who have been diagnosed with schizophrenia, so I decided to analyze this disorder and really align the most important things you need to know about it. I don't know what prompted you to pick up this book. Whether you already knew people with a schizophrenic mind or just got curious, just in case you do meet someone who is dealing with this disorder. Let me assure you that schizophrenia is prevalent enough that you'll be confronted with an individual or two at some point in life, and that it does help to learn more about it. With this book, you'll deepen your understanding, and you'll be more inclined to comprehend the complicated processes in a person's mind who innocently gets haunted by some of the difficult symptoms of schizophrenia. The information in this book is correct and accurate, and you will find that it will make sense, especially when you observe these symptoms in an individual you know or meet. Additionally, I will provide possible solutions for handling the disorder. As with many disorders, every person is different, and some solutions may only minimize the negative effects of the brain's malfunctioning. Others may help you work miracles as you notice significant progress in the individual's happiness and fulfillment in life. I encourage you to read through the pointers and notes in this comprehensive guide to understanding schizophrenia. One. Definition and delineation. Before discussing any of the deeper questions, let's begin with the most basic one that lays the foundation for all our understanding of it. What is schizophrenia anyway? For some reason, the popular media and the most common perception of schizophrenia is that of a split personality. This is false. Schizophrenia, despite its many possible symptoms, is in no way synonymous with having a split personality. Another myth is that those who have schizophrenia pose a constant threat to others. This is also false. The majority of those with schizophrenia are harmless, and I know what I'm talking about from first-hand experience, after interacting with several. The stats don't lie, and the fear of the unknown should be eliminated. Hopefully, I can enlighten you with the facts in this book so that erroneous concepts vanish from your understanding. So, what is it then? Schizophrenia is a serious, draining brain and behavior disorder that affects one's thoughts, feelings, and actions. Someone who has schizophrenia can have a hard time separating fantasy and reality, something that became clear to one of my family members who recalls whenever there was a scary part in a movie, he would just run away. For children who are 6 or 7 years old, this makes complete sense. But my schizophrenic brother still did it when he was 15. They can have difficulty expressing their emotions, controlling their feelings, or making clear decisions. Additionally, thought processes can be disorganized, and the motivation or passion to get something going could be minimized at certain times, thus leading to depression more often. Those who have schizophrenia may hear imaginary voices, something I have personally seen someone with the disorder express, and believe others are reading their minds, controlling their thoughts, or plotting to harm them. This is overly suspicious attitude may be noticeable in some and lacking in others. For example, the same woman I talked to mentioned that her cousin with schizophrenia thinks her aunt is a government spy, which is very unlikely. But her schizophrenic brother doesn't come from the same paranoia when it comes to people he knows. However, he does go on and on about how the US government is out to get us, and convincing him to eliminate gun rights is, therefore, never a good idea, since it always ends up in a heated discussion. The majority of those with this condition suffer from symptoms either unceasingly or sporadically throughout their lives, and are often severely defamed or judged by others who don't understand it. Nevertheless, the symptoms are scary to those who are afflicted by it, and can make them insensitive. disturbed, or solitary. Those with this condition attempt suicide more frequently than the majority of the population, and stats and estimates are based on a 10% risk the completion of a suicidal attempt within the first 10 years of illness, especially young men with schizophrenia. Although schizophrenia is a chronic disorder, it can be treated with medication, psychological and social treatments, substantially improving the lives of people with the condition. Despite the fact that I have only met male schizophrenics in my personal life, studies show that schizophrenia affects men and women equally. It occurs at similar rates in all ethnic groups around the world. Two, symptoms. After lightly touching on the symptoms of the disorder, I still think it's essential to go deeper and broaden our perspective. The way the disease manifests itself in someone differs from one person to another. The duration and severity vary, and how fast someone progresses and is able to overcome or handle these symptoms all relates to their background, environment, personality, and resistance to temptations, weaknesses, and outside forces. To clarify the symptoms even further, I have divided them into 3 different categories, according to different reliable resources: positive, negative, and cognitive symptoms. Positive symptoms. By the word positive, I don't mean beneficial, but rather symptoms that get added to their thought patterns and behaviors, which the general population doesn't experience at all or in the same degree. With this word, I am referring to something they feel that others don't, being the opposite of the negative symptoms that imply specific qualities or skills they lack or have in a lesser degree than the average person. Positive symptoms can include hallucinating, delusional thoughts, inner voices, and, at times, psychomotor problems such as clumsiness, forgetfulness, strange repetitive actions and routines, or awkward rigidity. A person close to me with schizophrenia, for instance, shows patterns of leaving his stuff at other people's places, forgetting what he was doing, or some other disorganized, chaotic way of neglecting the blandly obvious things in life, like brushing teeth or remembering an appointment. Delusions, hallucinations, and inner voices are collectively called psychosis, something that also appears in those with bipolar disorder. Delusions can make people feel too suspicious of someone's motives or become paranoid of being followed, stalked, or monitored. Hallucinations cause patients to sense, see, feel, or smell something unreal. Thought disorders may involve difficulty putting cohesive thoughts together or making sense of speech. Negative symptoms. This indicates symptoms that cause a loss in a certain behavioral area or brain activity. Emotion and motivation are 2 of them. Now, I know someone who has several signs of schizophrenia but hasn't been diagnosed yet. He doesn't want to do anything in life, says he is okay with becoming a bum, and shows little interest, if any, in pursuing a career or becoming self-reliant. Typical for schizophrenia patients is the inability to speak up, enjoy life, express their emotions, or initiate plans. Emotional flatness, passive resistance to initiative, social withdrawal, apathy, etc., which sometimes get confused with laziness or depression. Cognitive symptoms. Because in a patient's brain, sensors can get overloaded and the frontal cortex deviates from that of the average person, there can be problems with attention and memory. This means that they can get distracted easily, get addicted to the digital world, something I have seen a lot in those who have schizophrenia, and tend to be forgetful, which I mentioned earlier. Planning and organizing can be harder for someone with this disorder, and the results tend to be more chaotic and disorganized. These deficits stand in the way of many of them who try to lead a normal life. Three, subtypes. As I mentioned before, which should be obvious, every person with schizophrenia is different. Although certain symptoms are easily distinguishable as a general standard, an indication that someone has schizophrenia, and although these recognizable symptoms enable us to better understand them by shoving them into a category, there is another deeper layer that helps us more specifically pinpoint the kind of brain activity and deviate mindset a patient is suffering from. Therefore, according to psychological terminology and accurate research, I have maintained the same categories as have been found and determined by those who have studied this topic more elaborately. These subcategories, or subtypes, are paranoid schizophrenia, feelings of extreme suspicion, persecution, or grandiosity, or a combination of these; disorganized schizophrenia, incoherent thoughts, but not necessarily delusional; catatonic schizophrenia, withdrawal, negative affect, and isolation, and marked with psychomotor disturbances; residual schizophrenia. Delusions or hallucinations may go away, but motivation or interest in life is gone. Schizoaffective disorder. Symptoms of both schizophrenia and a major mood disorder, such as depression. Four, age. The symptoms of schizophrenia may be apparent when kids are young, but they typically do not get recognized as signs of schizophrenia. This is because many of the symptoms only appear at a later age. When someone with schizophrenia is young, people may see their behavior as autistic, Asperger's disease, or some other disorder. We clearly saw this in one of our family members, who had always been a little different than others, but who had some sort of emotional breakdown or burnout at age 21. It occurred when he got too many responsibilities, and when he stressed out because of a lack of consistency in the events happening around him. Just like those who have autism, someone with schizophrenia may have a harder or slower time adapting to change, because his or her thought processes are different, which sometimes just means slower. Therefore, one of the ways to help those with schizophrenia is to establish predictability and consistent routines and patterns. This was not the case in our family member at the time, which caused him to stress out and experience the clear signs of schizophrenia, which included hallucinations, hearing voices, the obsessions with being perfect, a lack of sleep, crazy talk, and randomly approaching people in the supermarket. Once we got him on medicine and helped him to eat and sleep more regularly, he partially recovered and came across as more sane. The psychiatrist mentioned that this was typical, to have the signs appear at such an age. According to scientists, hallucinations and delusions begin between the ages of 16 and 30. Men usually experience these symptoms earlier than women. After 45, the chance of getting schizophrenia is very low. And even though schizophrenia doesn't occur in children, the onset and the likability of being susceptible to it can often be noticed by the keen observer and well-informed therapist or caretaker. In teens, schizophrenia is difficult to diagnose because the first signs could include changing friends, a drop in grades, sleep problems, or becoming more easily agitated. Since these behaviors are common among teenagers anyway, it's often challenging to attribute them to schizophrenia or just regular teen drama and the everyday struggles of someone in that age group. Five, diagnosis. One can predict whether someone will have a psychotic breakdown in the form of schizophrenia or not, to some degree, so that surrounding family members, friends, and professionals can intervene more readily when extreme symptoms become apparent. A combination of factors can predict schizophrenia in up to 80% of kids and teens who are at risk of developing this disorder. These are some signs to look for that predict it pretty well. 1. Isolating oneself or withdrawing from others. 2. Irregular thoughts and suspicions. 3. A family history or hereditary genes related to psychosis. This stage of the disorder, when these symptoms appear, is called the predominal period. I have personally seen this in some people who have been diagnosed with, or bear many of the symptoms of schizophrenia. They talk about being incognito, anonymous, disappearing ninjas, pretending they are invisible so nobody can see them, sneaking around, disappearing from society, and they shy away from social settings. Of course, not every kid who is socially awkward or plays ninja games has many of these symptoms. Hey, I played ninja when I was a kid, but I have none of the other symptoms. Kids can have any of these symptoms and be only somewhat autistic, in a difficult period of their life, talented when it comes to developing a great imagination, etc. But when you see the genetic history, the siblings, the patterns, and certain other quirks that seem to be out of the ordinary, then don't rule out the chance of schizophrenia when diagnosing or predicting the disorder. However, these symptoms need to occur increasingly or more regularly over a long period of time, like several months, for example. A sudden one-time occurrence doesn't guarantee or suggest anything of the sort, and jumping to conclusions needs to be avoided as much as evading the putting on of labels to prevent people from thinking that your son or daughter is crazy. Something too many parents who refuse to help are afraid of, with all the consequences of not getting help and enhancing the severity of the symptoms. For someone to suspect schizophrenia in an already special needs individual, one must see 2 or more symptoms, like hallucinations, disorganized speech, random mumbling, delusions, stiff behavior, or an inability to cope with regular patterns or simple changes for several months. In the case of voices being heard that aren't real, or hallucinations in any form, one can assess the likability of the disorder, taking into account the personal circumstances of that individual, the time period of the symptoms, and the social or occupational problems that play a role as well. Researchers are working on developing more immediate intervention methods, as well as a greater understanding of how the environmental and genetic mechanisms form the brain cells that cause schizophrenia. As more is discovered about chemical circuitry and structure of the brains of people with the disease, better diagnostic tools and early intervention techniques can be developed. This is crucial for schizophrenia, as it is believed that with every psychotic episode, increased damage is done to the brain. The stress can be so high for them that scientists have presumed literal physical damage being done to the brain cells because of an overdose of anxiety, cortisol, and other negative additions. Cure and manageability. Even though, unfortunately, nobody has found a real permanent cure for schizophrenia yet, it is treatable and manageable with medication and behavioral therapy, particularly if the patient gets diagnosed early and treated continuously. This is why denial that there is something wrong with your child is hurting him or her more than if some of the odd behavior would be admitted as a serious problem and a possible disorder. Saving a few bucks on a therapist may not be as beneficial to them in the long run, when problems increase in severity and their lives and self-awareness have become less manageable. Patients who are experiencing critical problems, like serious delusions or hallucinations, suicidal tendencies, or the inability to care for oneself, may require hospitalization. Antipsychotic drugs currently are the best existing medications to decrease the various symptoms of schizophrenia. These have a positive effect on the brain's neurotransmitter systems. With the help of cognitive and behavioral therapy, the brain can be adjusted and symptoms can be brought down to a minimum. When an individual with schizophrenia cooperates and allows these trainings to have an impact on his or her life, coping mechanisms can be taught so that person can improve communication skills, get motivated, take better care of him or herself, attend school, get a job, or socialize. Regular psychosocial treatment helps such a person to cooperate when giving medication and reduce relapses and hospitalization. If the person with the disorder has a good relationship or friendship bond with the therapist, he or she is more likely to recover from relapses or the stresses of life. Seven, electrical stimulation. When I am talking about electrical stimulation, I am referring to a method called transcranial direct current stimulation, TDCS. Among others, it has been used to help those who have had strokes, as well as Alzheimer's and Parkinson's disease patients. It's non-invasive and without risks. A weak, small electrical pulse that can rearrange the alignment of the senses and brain tissues. TDCS is a technique in which a direct electrical current is passed through the cerebral cortex via electrodes placed on the scalp. Donald M. Martin, PhD of the University of New South Wales, who used a 2010 NARSAD Young Investigator grant to conduct studies with TDCS, says the method can potentially help the brain activity and inhibiting competing brain regions. Unfortunately, more research is needed to acknowledge if cognition related to psychiatric illnesses can be improved and help more than the original treatment sessions. It has been proven helpful in the past when it came to symptoms of depression, and it could be an option to be considered and discussed with physicians and clinicians. Eight, relapses. The first thing you need to do to prevent relapses and the negative effects of them is to recognize when relapses are occurring or most likely to occur, so that you can predict them with full confidence. Relapses are common because the tension in life and the vicissitudes that go with it constantly require people to adapt. Those with schizophrenia, this may be harder than to other people since they greatly benefit from consistency and routines. A relapse usually doesn't happen suddenly, and it is accompanied by other preceding symptoms which could include insomnia, anxiety, stress, tension, restlessness, depression, the inability to focus, less eating, being disorganized, disappearing unexpectedly, mood changes, having strange ideas that make no sense, poor personal hygiene, chaotic thinking patterns and weird conclusions, aggressive talk, suicidal thoughts, smiling for no reason, actual aggression, and/or breaking things. These are the predominant signs that precede a psychotic episode. I saw these in my specific friend when he had a psychotic breakdown. Responsibilities were too much of a burden for him. He couldn't handle the stress and sudden changes anymore, and he stopped sleeping and eating, which only made it worse, because he couldn't think straight anymore. Back then, we didn't know what we were dealing with, but the first things the psychologist recommended were melatonin so he could catch up on sleep and specific medicine for schizophrenia. Other symptoms may include withdrawal from social interaction, excessive preoccupation with religious ideas, and drastic changes of appearance, increased irritability, sadness for no particular reason, and extreme anxiety are also options. When I learned about this, it was very interesting to me, since my friend randomly went to people in the supermarket and began talking to them, saying that they were great and perfect people, and other nonsensical phrases. He was obsessed with religious ideas and became more preachy and interested in spirituality, quoting random Bible scriptures and claiming he heard evil voices that kept him awake. He smiled a lot for no reason, and he talked about suicide or taking a knife and hurting himself in the kitchen. All of these things happened several days before the breakdown, and it is exactly those prodromal signals that should be regarded as warning signs and a call to intervene with medicine and/or professional help. When schizophrenia is under control and the symptoms stop, it may be tempting to think it is all over, but relapses like this can happen, which means the symptoms come back. If any of you notice the prodromal signs which are a prelude to a relapse, contact your doctor right away, or adjust treatment and medicine. Always check if that person is still taking his or her medicine. Here are some tips to avoid relapses. 1. Take medicine as instructed. even if symptoms aren't evident anymore. One of the most common causes of relapses is patients who quit taking their medicine. 2. Completely avoid alcohol or illegal drugs. They make symptoms worse and are a big cause of relapses. 3. Find more positive ways to manage stress. Stress is one of the biggest symptom triggers for those with schizophrenia. Take it easy, take a break, and don't wear yourself out. Find healthy ways to relax. 4. Exercise for at least 30 minutes per day. Exercising is very important. If you have to, find a program, a class, or a partner so you can stick to this routine. 5. Get enough sleep. This is extremely important. A lack of sleep makes the brain go nuts. This could happen to any person, but more particularly to those with schizophrenia. 6. No caffeine. This will just keep you awake and worsen the symptoms. 9. Crisis. Reversing the symptoms of a could-be psychotic breakdown is essential, and regarding to that, preventing the symptoms from escalating is the main purpose of any professional, bystander, friend, or family member dealing with someone who has schizophrenia. One of the things you can do, and this has been tested, is speaking softly and in simple sentences. People will seldom lose control if they are approached in a soft, gentle way. This way, sleeplessness, stress, ritualistic preoccupation with specific activities or topics, suspiciousness, or sudden outbursts will be less likely to occur. Do nothing to agitate the patient. If you feel threatened, then protect yourself and take immediate action. The more psychotic the patient is, the less likely you will have success. As mentioned before, psychosis can be prevented by reacting to the symptoms in the early stages, the ones that precede the psychotic breakdown and mania. Remember that the patient is probably scared because of the loss of control of feelings, behavior, and thoughts. The voices may come in different forms, and they may form a threatening message to the person who is victimized by his or her own twisted brain. Hallucinations may beseat that person, and he or she may act out accordingly, like trying to kill the snakes that he or she sees crawling through the window, thus shattering the window to end it. Always remain calm, no matter how hard this may seem in such a situation. If you are alone, call someone to stay with you until professional help arrives. If the patients must be hospitalized, avoid patronizing or forcing, and ensure him or her that going with you voluntarily will have the most positive outcome for everyone. If it goes too far, the police might have to come. Always explain the mental illness to them and assure them that the use of weapons won't be necessary. Here are some other things to avoid: threatening, yelling, criticizing, blaming, arguing with other family members, standing higher than the patient, saying no to requests unless they are endangering or beyond reason, blocking the doorway. Fortunately, my friend with schizophrenia did not act out aggressively. He was a very friendly person with no history of anger issues, and he did not come across as a threat to others. However, caution should always be taken when dealing with those with schizophrenia, and the above advice is still valid. (10) Self-help. Fortunately, most patients with schizophrenia improve over the years. Stats have shown that at least 20% will get better within 5 years of the first symptoms. 60% will get better, but will still have the occasional symptoms, and only 20% will still have troublesome symptoms in the years to come. Sadly, recovery from schizophrenia means nothing more than coping with it. A schizophrenic's life may never be completely free from symptoms. But with that being said, a patient's life may still be creative, purpose-driven, satisfying, and blissful. The two most helpful factors of therapy and medication can be combined with self-help, which can motivate and push a schizophrenic's desire to achieve and go somewhere worthwhile. The encouraging thought here is that schizophrenia is treatable, even though it's not curable. If a patient believes this, he or she will be more motivated to make changes. Another thought is that those with schizophrenia can have happy relationships, valuable professions, and participate in meaningful activities. Just because you have schizophrenia doesn't mean you have to be hospitalized a lot. My friend never got hospitalized, and with the help of medication, support from family, and a professional, he was able to get over his psychotic episode quickly. Also, keep in mind that most people with schizophrenia improve, as indicated earlier, and that there is no reason to despair. Other self-help strategies include 1. Stick to your diet. Don't stuff yourself with unhealthy food, and exercise enough. Participate in stress-relieving activities. Seek social support. Listen to your therapists and doctors. Take a little step to achieve things so that your self-esteem will get in the way of any suicidal thoughts that may occur. 6. Change your attitude to schizophrenia and see yourself as an intelligent, capable person who just needs a little help. You are not crazy. In fact, you probably have certain talents nobody else possesses. My friend was an expert at chess, programming, and math. Yes, he was a little geeky, but if you ask me, he had quite the impressive skill set. An employer once asked him to perform a specific task in 10 days. He did it in only a day, and every detail was executed perfectly, and all of that without a college degree, being self-taught through taking courses and watching YouTube videos on the internet. 7. Try to distance yourself from any delusional thoughts that may come your way. Just realize that sometimes the way you look at things may be a little exaggerated or influenced by schizophrenia. This way, you can ignore maleficent voices in your head and stay free from the consequences of hallucinations. 8. Have a goal plan. This may work even better for you than some other disorganized people who don't know what they want. My friend with schizophrenia used an internet video game that was focused on goal setting to get points for every little deed of exercise, work, study, cleaning, or other useful activities. His obsession became collecting points, but it kept him on track, and he accomplished a lot more just by being motivated by a system of simple rewards. 9. Don't allow family to deny the fact that you have schizophrenia. Nobody likes a label, and parents will often go through extensive lengths to deny that their child is not normal. Face reality and deal with the consequences without thinking that there is something wrong with you, whatever that means. I mean, seriously, isn't there something wrong with all of us? We all have to work on our flaws. (11) Activity. The effects of exercise reach far beyond what many people comprehend. Regular exercise can manage symptoms of schizophrenia, help you sleep better, and digest food better, and relieve stress. People aren't made to sit still. They are made to move. Exercising gives you more energy to accomplish things, prevents psychotic episodes, and makes you feel calmer. Trust me when I say this. The moment I am running, I feel awful. I feel like I am out of oxygen, my legs could collapse, and like I am getting dehydrated. But the moment I come home, shower, and lie down on the couch, I feel better than ever before. That's just how sports work. Ideas for exercising are swimming, running, dancing, playing ball sports, working out at the gym, or just going on a walk. 12. Individual support. Watch out for loneliness. Isolation and being alone all the time make you close off yourself from the rest of the world. Human beings aren't meant to be alone, or even to feel alone. Although, unfortunately, there are many people who feel that way, so regular contact to connect with trusted individuals is important. You need people to take you seriously enough and won't criticize, distract, or judge you. The support of others can truly prevent relapses. Trusted friends and family members form the basis for such a support group. But you can get social support at work, volunteer projects, church, or in other circumstances as well. You can also join a schizophrenia support group, which is something that may help you feel understood more. I'll expand on that later. The last option is mental health clinics. You could look them up and see if it's something that you would be interested in. Most times, these clinics have trained professionals and staff who know exactly how to assist you. 13. Managing stress. Stress is the biggest thing to avoid, especially in this modern age of electronics, pressure to perform, individualism, and time management. I personally know more people who have overworked than people who are lazy or bored. I see phone messages and notifications all day long, whether it's on my own phone or someone else's. Today is a fast-paced society, and living with a difficult emotional disorder doesn't make things easier. If you are not careful, the tasks, responsibilities, and pressure to accomplish more than others can drive you nuts, as it can with any other person. If stress occurs, high levels of cortisol, the stress hormone, get released, and these chemical fluids may trigger psychotic episodes. I already mentioned exercising, dieting, and staying connected. But here are some more quick tips to manage stress. Make use of relaxation techniques for stress relief. Mindfulness, meditation, deep breathing, yoga, listening to music, or progressive muscle relaxation can help your mind and body and put you at ease. When I was in Asia, I heard some Buddhists say, when you feel anxiety, focus on breathing. People who are angry breathe fast. If you breathe slowly and deeply, you can more easily control your emotions. Be aware of your limitations. Don't try to do more than you can handle. You don't want to feel overwhelmed. Control your emotions. Balance your moods and maintain control over your life. Accept negative emotions, such as anger, sadness, disappointment, or frustration, without beating yourself up about it or letting others tell you that you cannot feel this way. Just control the way you express them. Here's another book that can help you when you are trying to control your emotions. Emotional Mastery by Rita Chester. 14. Taking care of yourself. This is something that may sound obvious, but for some schizophrenics, it is a special challenge. You see, when your brain is more disorganized at those moments that you just don't know anymore, it is hard to keep up with the regular things of life. My friend with schizophrenia, for instance, has a hard time keeping track of his stuff, and simple routines such as keeping track of PayPal expenses and purchases, brushing teeth, or flushing the toilet, you could say he is just sloppy, sometimes, and he is probably not to blame for it. Whenever he comes over, there is a high chance he leaves a jacket, a book, a bag, or a cord at our place because at the time he leaves, he is a little scatterbrained and just forgets about it. However, he never forgets his laptop because he is very attached to it. Besides the daily challenges, I noticed something else in him. When he had a psychotic breakdown, which only happened twice, one time worse than the other, he didn't sleep or eat enough, which became a huge problem. Make sure you involve these things in your schedule, even when you are obsessed or just very interested in a particular topic or activity. 15. Medication. Medication is essential, and I cannot emphasize it enough. Yes, even a skeptic like me, when it comes to taking pills and all the useless stuff out there in the corrupt industry of medical assistance, is convinced that the medication prescribed by those who diagnose someone with schizophrenia is valid and useful. Medication is not a cure, understand that, but it provides relief from severe symptoms like hallucinations, delusions, paranoia, and disorganized thinking patterns. Lack of motivation or emotional expressiveness, as well as social skills, cannot be helped. But those are things you need to work on yourself and with others. The downside of medication for schizophrenia is that it can have annoying side effects, which is why some patients don't want to take it anymore. Drowsiness, uncontrollable movements, weight gain, less energy, and sexual dysfunction have been reported by the faithful users of it. It's important that you know exactly how much you should take. So, consult with your doctor on the minimum. Never reduce or stop taking this medication on your own without asking for advice from professionals. They should be the only ones who can estimate the right dosage. Sudden unsupervised quitting can have dangerous consequences and can cause relapses more easily. Typical antipsychotics have a track record of successfully treating paranoia and other psychotic symptoms. They are a little older and are prescribed less frequently because they can have extra pyramidal symptoms like tremors, temporary paralysis, slow movements, restlessness, muscle spasms, or changes in breathing and heart rate. Long-term intake of schizophrenia antipsychotics can cause dyskinesia, which can cause involuntary facial tics in the tongue or mouth, or uncontrolled tiny movements of limbs, trunk, or feet. The risk is only about 5%, but it is still there. Because a lot of patients need medication for longer time periods, sometimes their whole lives, it is crucial to find out the best dosage is so the symptoms can be minimized while still benefiting from the positive effects and the antipsychosis effects of the medication that has been prescribed. People are different, and every medication will have a different effect on a different person. Therefore, it is not set in stone, and it is a trial and error process to figure out the perfect fit for the best quality of life. Also, it takes some time for antipsychotic medication to take effect. Some only take several days, while others may need a few weeks or even months to have the desired effect. If the effects are insignificant within about 6 weeks, help should be sought after. Other medication may be complemented aid to help you control other aspects of your psyche, like antidepressants or anti-anxiety drugs that can help the brain's neurotransmitters and dopamine dosages. Some people are more vulnerable to some ways of taking medication than others. For this reason, some patients prefer taking injections over taking pills, and others may prefer the opposite. (16) Second-generation antipsychotics. As briefly mentioned in the previous points, there are older and newer medications, each with their own risks and benefits. These are the newer medications, the second-generation medications that pose a lower risk of serious side effects, but still can have some side effects like drowsiness, weight gain, reduced energy, or sexual dysfunction. These newer improved antipsychotics can be aripiprazole, Abilify, acinapine, Saffris, brexpiprazole, Rexulti, cariprazine, Vraylar, clozapine, Clozaril, iloperidone, Fanapt, lurasidone, Latuda, olanzapine, Zyprexa, paliperidone, Invega, quetiapine, Seroquel, risperidone, Risperdal, ziprasidone, Geodone. 17. First-generation antipsychotics. Since finding the right medication for the individual's needs is a trial and error process, some prefer the first-generation antipsychotics, which can have neurological effects like movement disorder, restlessness, or muscle spasm. I mean, choose your own poison is really what it comes down to. The best fit will be an individual's and doctor's choice. Make sure you take the advice from your psychiatrist seriously. The first-generation medication is often cheaper than the newer ones, especially generic versions, which can be a good long-term solution when needed. The first generation medication could be chlorpromazine, flufenazine, haloperidol, perfenazine. (18) Psychosocial interferences. Social skills and stress control can be acquired by the right motivation and help. Psychosocial interference can be done by coaching or in group therapy sessions. Some patients choose to participate in improving their communication skills, social interactions, and daily activities normalization by following a specific training program. Some programs include family therapy, where they involve the schizophrenic's family members. Others focus on more job-oriented skills and employment gain so that the individual with the disorder is more likely to find a sustainable job and take care of him or herself. Sometimes, depending on where you live, there is a financial or self-dependency program supported by the government, a charity, or the locals that specifically help people with schizophrenia stand on their own 2 feet. Some provide housing, vocational skills, and other treatment and life necessities. (19) Therapy tips. In individual psychotherapy, a psychiatrist teaches the schizophrenic to deal with his or her thoughts and reactions. The therapist can also help the patient to distinguish reality from imagination and manage everyday life. In cognitive behavior therapy, the focus is on minimizing psychotic episodes and learning to deal with voices, delusions, and hallucinations. Psychosis will be prevented through advice and medicine. Then, there is cognitive enhancement therapy, or cognitive remediation, which helps patients to recognize social signs, triggers, or improve their memory, attention span, and attentiveness. This kind of therapy focuses on organizing one's thoughts, and it often includes computer-based brain training and group sessions as well. And last but not least, there are self-help groups which are like addiction recovery programs. These outreach programs help with working on social skills and sharing. The National Alliance on Mental Illness is such an organization. There are 10 sessions for patients with a mental illness in it, and it is for those who want to learn more about themselves or a loved one. (20) Final tips. In this book, I've already given a lot of tips. Here are some final words. Take these things to your heart and help yourself or your loved one to cope with schizophrenia. 1. Learn more about it. The more information you have, the better. You already took the first step by learning the basics through the information in this book. But I am sure there is a whole library out there with other sources that can enlighten you and expand your mind further. 2. Take notes when you go to the doctor. This may seem simple, but it can help you to better remember and understand the disorder and the steps you need to take to minimize the negative effects. Take notes about the symptoms, the past experiences, other medical conditions, new sources of stress, and changes in life. Vitamins, herbs, or supplements the patient or you has taken, etc. 3. Learn how to react to the person with schizophrenia. It doesn't help, for example, to tell him or her that the things they are seeing or hearing aren't real, because even if they aren't, he or she still senses them. It's better to say that you see things in your own way. Respect, friendliness, and support are crucial. If the patient feels threatened and tensions arise, make sure to avoid eye contact, because this will enhance his or her feeling of insecurity. If the patient threatens to commit suicide, don't ever leave him or her alone. Call for help. 911 if needed, if you live in the USA, of course, or the local emergency number in any other country. 4. Get the Psychiatric Crisis Resources Kit app. This is downloadable on your iPhone or other device. 5. Know the signs of suicidal tendencies. People with schizophrenia are more likely to hurt themselves than others. If they talk about suicide, take them seriously. Pay attention to anecdotes, notes, poems, or subtle comments. If he or she goes from depressed to cheerful, don't trust it. This can all be an act, and this change could mean he or she is thinking about committing suicide. Stay suspicious when something like this happens. 6. Keep contacting them. If a schizophrenic is left alone too much, suicidal thoughts may increase. Stay in contact via texting, email, mail, telephone, Skype, or the occasional visit. Remind them how much you care. That was it. I hope you enjoy the information in this book. I certainly put my heart into this, since I personally know someone close to me with schizophrenia. Thanks again for buying my book. If you have a minute, please leave a positive review. I take reviews seriously and always look at them. This way, you are helping me provide you better content that you will love in the future. A review doesn't have to be long, just 1 or 2 sentences and a number of stars you find appropriate, hopefully 5 of course. Also, if I think a review is useful, I will mark it as helpful. This will help you become more known on Amazon as a decent reviewer and will ensure that more authors will contact you with free ebooks in the future. This is how we can help each other. Take a look at my other books too. Hoarding, OCD, Midlife Crisis, Bipolar Disorder. This has been Schizophrenia, 20 Symptoms and Treatments of This Mental Illness. Written by Albert Rogers. Narrated by Matthias J. Copyright 2017 by Albert Rogers. Production copyright 2017 by Albert Rogers.
Multiple Personality Disorder, a concise analysis of dissociative identity disorder, written by Quinn Spencer, narrated by Eric Boozer. Dissociative Identity Disorder, DID. Dissociative Identity Disorder was previously called as Multiple Personality Disorder. The person with DID possesses 2 or more distinct personalities and work according to any personality alternatively without knowing. Sometimes a person also experienced memory loss or forgetfulness. DID is nothing but one of a group of conditions called dissociative disorders. Dissociative disorders are a kind of mental illness which cause memory disruption or breakdown. Symptoms of DID. A person with DID has 2 or more distinct personalities, including the person's usual personality and alternate personalities. A person may experience amnesia when alternate personalities take control over the person's behavior. An individual with DID may or may not be aware of the other personality states. Each alternate personality has distinctive individual traits, personal history, way of thinking, etc. In fact, alternate personalities may be a different gender, have a different name, or a distinct set of manners and preferences. DID shares the following psychological symptoms. 1. Amnesia, memory loss or feeling a time distortion. 2. Anxiety. 3. Changing the quality of functioning from highly effective to disappointing. 4. Depersonalization, feeling disconnected from one's own thoughts, feelings, and body. 5. Depression. 6. Derealization, feeling that the surrounding environment is foreign, odd, or unreal. 7. Disturbances in eating and sleeping. 8. Hallucinations, false perceptions or sensory experiences, such as hearing voices. 9. Problems with functioning sexuality. 10. Self-injurious behavior such as cutting. 11. Serious headache or pain in other parts of the body. 12. Substance abuse. 13. Suicide risk. 70% of people with DID have attempted suicide. Causes of DID. The previous incidents are the key features of dissociative identity disorder. In fact, 90% of the cases of DID involve some history of abuse. The trauma also involves severe emotional, physical, and sexual abuse. It might also be linked to accidents, natural disasters, and war. The episodes of DID can be triggered by myriad real and symbolic traumas, including minor traffic accidents, adult illness, and stress. There are following causes of dissociative identity disorder. 1. An innate ability to disassociate early. 2. Repeated episodes of severe physical or sexual abuse in childhood. 3. Lack of supportive or comforting person to counteract abusive relatives. 4. Influence of other relatives with dissociative symptoms or disorders. Treatment of DID. The main objective of DID treatment is to relieve symptoms, ensure the safety of the individual, and changing multiple personalities into one integrated and well-functioning identity. The treatment also aims to help the person safely express and process painful memories, develop new coping skills and life skills, restore optimal functioning, and improve relationships. In fact, the best treatment approach depends on the individual, the nature of any identifiable triggers, and severity of the symptoms. Most likely treatment includes the following methods. 1. Psychotherapy. It is also known as talk therapy. It is the main treatment for dissociative disorder. It is a broad term that includes several forms of therapy. 2. Cognitive behavioral therapy. This is one of the forms of psychotherapy, which focuses on changing dysfunctional thinking patterns, behaviors, and feelings. 3. Eye movement desensitization and reprocessing, or EMDR. This treatment technique was created to treat people with persistent nightmares, flashbacks, or other sites of post-traumatic stress disorder, or PTSD. 4. Dialectic behavior therapy, or DBT, a form of psychotherapy for people with severe personality disturbances, which can involve dissociative signs that often occur after an experience of abuse or trauma. 5. Family therapy. This helps a little in order to teach the family members about the disorder, as well as the family members recognize signs of a reoccurrence. 6. Creative therapy. These therapies include art therapy and music therapy, which allow patients to explore as well as express their feelings, thoughts, and experiences in a safe and creative environment. 7. Meditation and relaxation techniques. These help people to better tolerate their dissociative signs and become more aware of their internal states. 8. Clinical hypnosis. This is also one of the treatment methods which uses intense concentration, focused attention, and relaxation to achieve an altered state of consciousness. This allows people to explore thoughts, feelings, and memories which may be hidden from their conscious minds. 9. Medication. Medication is necessary in order to provide proper treatment to the patient. In fact, an individual with IDD must be treated with anti-anxiety or antidepressant medication. Benefits of having multiple personalities and dissociative identity disorder, DID and MPD. 1. Being able to do more than one thing at the same time. Talk about having the ability to multitask. I've known situations where one personality can be talking comfortably on the phone while another personality is busy doing the day's work. How cool is that? 2. Always having someone to talk to. When you are friends with each other on the inside, you don't ever have to be alone. Your best friend can be right there with you, any time of the day or night. 3. Being able to maintain the joy of a child's perspective. Children can be so innocently full of wonderment and joy and happiness. They know how to be carefree and happy and amazed at the simplest of life's pleasures. Child parts, once safe from trauma, can keep the sense of joy near to them their whole lives long. 4. Being able to take a break even when the outside body has to keep going. When you're split, you can tuck back inside and rest or sleep or think and let someone else be out in front managing whatever is going on in life. Having the ability to pull away and separate from the outside life can come in handy sometimes. 5. Having the ability to remember so much more of life's experiences. In my opinion, once a person with dissociative identity disorder finds safety and learns to connect with all their internal people and lowers the dissociative walls, it seems to me that people with DID actually remember more of their life than regular singletons do. This includes remembering more of the good times as well as the bad. 6. Having the ability to understand life and events from a variety of different perspectives. Those with DID don't have to imagine what it would be like from a different perspective. They often have someone inside that already genuinely sees things that way. 7. Blocking out pain. While blocking pain is not always a positive or helpful skill, there are times and places where having the ability to block out pain, both physically and mentally, can be a great benefit. 8. The ability to fit in with a variety of different people. While some system splits were formed as trauma-based ways of matching with various groups of people, and some not so good as others, the positive flip side of that ability is that people with multiple personalities can literally find themselves fitting in easily with a wide variety of people in a variety of ages. The point being, despite the difficult beings required in splitting into multiple personalities, there are many good and positive attributes to being multiple. For those of you that are multiple, what do you enjoy about your multiplicity? What strengths do you have? How has multiplicity enhanced your life? What qualities of being a multiple would you want to keep and never lose? Why do some people have split personalities? This disorder usually begins in childhood as a defense against prolonged trauma, usually some kind of abuse, either mental or physical. The theory is that the mind splits in two, so that it can retreat into the other personality or personalities in times of extreme distress, and to allow the newly created part to take some of the burden of distress by sharing the pain. Another explanation, and this seems more likely, could be that the mind is creating an untouched personality, knowing that the original one has been severely corrupted. Much like when we partition a hard drive, in case one part becomes corrupted, then we still have the other clean partition to work with. And the reason each part knows nothing of the other and its experiences could be to protect it from the corruption and disorder of the abused part in order for that newly created part to function properly. If the new part had any memory or knowledge of the abuse the other went through, it would become damaged. How do these dramatic physical changes happen? If the mind and body are linked as closely as this suggests, then it would seem that the memory, experiences, and beliefs of the person are linked to every cell in the body, so that when the person changes personality, all previous beliefs and so on are completely erased from the duration, therefore changing the whole biology, molecular structure, cell structure, and chemistry of the body according to the new part. So what does this all mean, and how can it help us? This is showing us how powerful the human mind is, and that our bodies and their ailments, both mental and physical, are not permanent, but can be changed by the power of belief and thought. If we believe something without doubt, surely we can affect our own bodies at the cellular level, just as people unconsciously do with multiple personalities. We could just imagine that we are healed and it would happen. We could see in our mind that the cancer has gone and it would be done. Disease of every kind would be a thing of the past. All we need is the unwavering belief of our inner power. And the seemingly strange things that occur with people with multiple personalities should give us this belief. There are many ways we can utilize this mind power. Through hypnosis, we can gain access to the subconscious to create new beliefs using visualization and other transformation techniques. Hypnosis is well known to be able to create the same phenomena described in this article in emotionally normal people. Even without formal hypnosis, a person can learn powerful visualization techniques, which, if vivid enough, can be very powerful. Visualization works because the mind cannot differentiate between mental images and real images. So if we see something vividly enough and for long enough, the body's cell structures will begin to conform to what is being seen in the mind. Just like when a multiple personality takes over from a previous one, his cell structure and mental state is changed according to the beliefs of the new part. Myths about dissociative identity disorder. There are a lot of misconceptions about dissociative identity disorder, or DID. Here are some common ones. Do you have an evil alter? I've heard people with DID are dangerous. This is a common misconception which isn't helped by media portrayals of split personalities, like the characters Jekyll and Hyde, and sensationalized films like the 2017 movie Split. Those with DID, like most mental illnesses, are more likely to be a danger to themselves, not others. There are no evil alters. There can be destructive alters, but they need the same amount of compassion as any other member of the system. You can develop DID as an adult. The only possible time that DID can form is in early childhood, generally accepted to be before ages of 6 and 9 at the latest, because normal personality development that occurs at this age is interrupted by trauma. Traumatic experiences that occur later than this age can lead to other conditions, such as post-traumatic stress disorder, or PTSD, but not DID. DID is the same as schizophrenia. They are two very different disorders. According to the ISSTD, DID is a dissociative disorder developed through chronic childhood trauma and characterized by the presence of two or more distinct identities or personality states that recurrently take control of the individual's behavior, accompanied by an inability to recall important personal information that is too extensive to be explained by ordinary forgetfulness. Schizophrenia, on the other hand, is a psychotic disorder potentially caused by a number of factors, including genetics, biology of the brain, and stress. It is characterized by delusions, hallucinations, paranoia, disorganized speech, etc., which causes significant social or occupational dysfunction. DID isn't real. Stop pretending. DID is very real, and there is a lot of evidence supporting it. Despite this, it remains a controversial diagnosis to some professionals. Stigma surrounding the disorder can unfortunately sometimes include professionals, despite DID being a recognized psychological condition in diagnostic manuals worldwide. DID is so rare you can't possibly have it. It isn't actually as rare as you may think. The ISSTD, International Society for the Study of Trauma and Dissociation, accept that up to 1 to 3% of the general population have DID. This is roughly the same amount of people who possess the ginger gene. If you really had DID, you wouldn't know about your alters. It's fairly common for those with DID to know about their alters. Many report hearing others talking inside and can be aware of other selves, even in childhood. Many individuals will not remember what they have been doing for periods of time and can behave completely out of character. This is an extremely confusing experience, especially prior to receiving psychiatric support. Internal communication between alters is often worked on and improved through therapy. You can't have DID, I would have noticed. Often switches between alters are not obvious to those who don't know what to look for. If you know someone with DID well, you may notice slight differences in body language, vocal differences, differences in handwriting, differences in vocabulary, etc., that would otherwise go unnoticed. When DID develops in childhood, it is to protect the child from trauma and allow them to have as normal a childhood as possible. It is meant to go unnoticed. Everyone has multiple personalities. Everyone has different aspects of their personality and different sides to themselves that are needed in different circumstances and at different times. Alter personalities are not just representations of different emotions, but disassociated parts of the personality that have their own identities, including their own age, gender, interest, dislikes, opinions, and ways of interacting with the world. Alters only exist in DID and OSDD, otherwise specified dissociative disorder, and are not developed consciously. You can't have more than 5 alters. That's just not possible. The size of a DID system depends completely on the individual and their needs. Once DID develops as a child's coping mechanism, it may continue and further splits may occur throughout life in times of trauma or extreme stress. The diagnostic criteria only specifies that there must be 2 or more alters, and there are cases of hundreds of alters within one body. Polyfragmented DID, which is often a result of more organized and extreme abuse. Switching always causes complete amnesia. While there is often lost time experienced by those living with DID, also called dissociative amnesia, co-consciousness can also occur. That is, when more than one member of the system is experiencing the external world at the same time, and they are aware of each other's presence. You can't have non-human alters. Non-human alters are fairly common and recognized by professionals. There are several reasons why non-human alters may develop. For example, if a child is treated like an animal, or if they identify with animals more than humans as friends or protectors. Integration is the only way to treat DID. Despite this being the aim of therapy in the past, a lot of professionals now recognize this isn't the only treatment option for those with DID. Improving cooperation and harmonious coexisting of alters is often the main therapeutic goal. People with DID can't function or lead a normal life. The prognosis of DID is actually quite positive, with many people successfully pursuing careers and having families. Like with other mental illnesses, recovery takes time, may include a number of treatment options, and is an ongoing process. Prevalence and controversy over dissociative identity disorder, or DID. DID is diagnosed most frequently in adulthood, and the literature indicates that females are more frequently affected than men. More than 5 times as many women than men are coming forward for diagnosis of DID. The disorder is no longer rare, and there is a sharp rise in reported cases of DID diagnosis in recent years. This increase in numbers brings about a controversy among mental health professionals. Some contend that the increase in diagnosis can be explained by the notion that the mental health community is now more aware of the diagnosis, and that this has resulted in the identification of cases that previously may have gone undiagnosed or inaccurately diagnosed. Also, it could be suggested that along with an increased awareness of DID, an increased awareness of childhood sexual abuse may have also led to earlier, more accurate diagnosis. An alternate view is that the recent increase is due to the overdiagnosis of DID, specifically within individuals who are considered highly suggestible. It is clear that DID remain a controversial diagnosis. Does DID exist or not? Is it a subjective perception of the reality by individuals based on their choices, or is it a result of malingering and a way of coping with social and personal situations? From the studies that have been performed by choosing randomly among families in countries with high rate of DID occurrence and with no knowledge about the disorder, results that the disorder is apparent, but there is more to be done in educating the public to treat the disorder as other more popular diseases are treated. Benefits of having multiple personalities and dissociative identity disorder, DID and MPD. 1. Being able to do more than one thing at the same time. Talk about having the ability to multitask. I've known situations where one personality can be talking comfortably on the phone while another personality is busy doing the day's work. How cool is that? 2. Always having someone to talk to. When you are friends with each other on the inside, you don't ever have to be alone. Your best friend can be right there with you, any time of the day or night. 3. Being able to maintain the joy of a child's perspective. Children can be so innocently full of wonderment and joy and happiness. They know how to be carefree and happy and amazed at the simplest of life's pleasures. Child parts, once safe from trauma, can keep the sense of joy near to them their whole lives long. 4. Being able to take a break even when the outside body has to keep going. When you're split, you can tuck back inside and rest or sleep or think and let someone else be out in front managing whatever is going on in life. Having the ability to pull away and separate from the outside life can come in handy sometimes. 5. Having the ability to remember so much more of life's experiences. In my opinion, once a person with dissociative identity disorder finds safety and learns to connect with all their internal people and lowers the dissociative walls, It seems to me that people with DID actually remember more of their life than regular singletons do. This includes remembering more of the good times as well as the bad. 6. Having the ability to understand life and events from a variety of different perspectives. Those with DID don't have to imagine what it would be like from a different perspective. They often have someone inside that already genuinely sees things that way. 7. Blocking out pain. While blocking pain is not always a positive or helpful skill, there are times and places where having the ability to block out pain, both physically and mentally, can be a great benefit. 8. The ability to fit in with a variety of different people. While some system splits were formed as trauma-based ways of matching with various groups of people, and some not so good as others, the positive flip side of that ability is that people with multiple personalities can literally find themselves fitting in easily with a wide variety of people and a variety of ages. The point being, despite the difficult beings required in splitting into multiple personalities, there are many good and positive attributes to being multiple. For those of you that are multiple, what do you enjoy about your multiplicity? What strengths do you have? How has multiplicity enhanced your life? What qualities of being a multiple would you want to keep and never lose? Daily tips for living with dissociative identity disorder, or DID. Here are some tips on reducing the headache of living with dissociative identity disorder, or DID. There really are no hard and fast rules for dealing with it, unfortunately, since what worked well yesterday might not today, and what works for one personality might not work for the others. So knowing all that, here are 10 general tips for living with DID on a daily basis. The number one thing to remember with all of this is, be flexible. 1. If you drive, get yourself a GPS, global positioning system. Depending on how fragmented you are, which of the alters drive, and what's going on inside the system, is it chaotic, calm? Is everyone mostly working together? Sometimes the body ends up across town, or worse, halfway across the state, or further, before you realize it. Here's how it goes. One minute you're standing in your kitchen cooking dinner or talking to your significant other. Blink your eyes, and the next minute you're behind the wheel of your car without a clue as to where you are going, why you're there, or how to get back. Program the GPS for home first thing. 2. Put up an internal whiteboard or keep an external notebook. One of the most important things you can do to try to keep some sort of conscious continuity between your parts is to make it mandatory that all of you keep notes in some central notebook or internal whiteboard. Because we tend to lose time due to personality switching, it is vital that detailed notes are kept. Some people are able to keep an internal whiteboard where the alters write notes of important things they've done or committed to, doctor's appointments, dates, exams. Others keep an external notebook that everyone writes in. 3. Let people around you know how to call out your more cooperative personalities, just in case. Sometimes when the system is in chaos or is having a panic attack, it is helpful that someone around you that you trust is able to call out a calming personality, one that will get things under control for the system. But only do this if you're comfortable and trust the person. Otherwise, the shout-out won't do any good. In fact, it might trigger a protector, personality violent alter. 4. Secure your funds. Understand that there are more than just you spending your money and wanting to spend your money. So if you have bills to pay, pay them first as soon as you have money. Better yet, have the bills on auto pay or try to prepay them so that you don't have as much debt. That way, the bills get paid whether you remember or not. Have it so that all your financial responsibilities and living necessities are taken care of first. That way, any money remaining can be spent and it won't affect your lifestyle. Set up a 2-signature requirement for checks if possible, and avoid keeping an ATM card on you. 5. Have a place for important papers or unexpected documents, traffic tickets, IRS notices, etc., and make sure that everyone in the system knows to have a look at that place when they are out. This falls in line with trying to keep as close to a continuous consciousness as possible. Not all alters are considerate or care to cooperate with the others. Some are extremely reckless, in fact. Make sure you keep all your documents in one place. Here's a real-life example of why. Imagine you're in your car and for whatever reason you get pulled over and find out you have outstanding tickets and a warrant. That would annoy even the most gentlest of people. Something similar to this happened to me. So make sure you keep your papers in one place, no matter how horrible. This is a tough tip to adhere to, as you'll have to get the others to agree and not hide stuff. Be willing to be a mediator. 6. Keep an emergency contact phone number, next of kin, in your purse, wallet, and/or cell phone. Even people without DID should have this information handy. For those of us with DID, though, it is also important that we have the contact information of our psychiatrist and our therapist or treatment facility. 7. Set up a safety network for yourself in case of a panic attack or similar emergency. It is so important to have a support team when you have DID. Your team might include your significant other, understand friends, your therapist, even your child. It is also important for me to say that it isn't always necessary that any of these people know that you have DID either. People that care about you will assist you any way they can, and most times without asking a lot of questions. Seek out those people you can trust and build your safety network from there. 8. Keep all prescription drugs secure and keep a journal of when you take them. Unfortunately, there are alters who are suicidal and who hate the body in general and hate all the other personalities as well. At some point, these alters do come out and sometimes harm the body, either by putting it in dangerous situations, by self-mutilating, or attempting drug overdose. So it is best to keep the drugs in a location that these alters don't know about. It is also a very good idea to keep a log of when you take your medication. Otherwise, if an alter comes out and doesn't know you've already taken your required dose, that alter may take another dose as well. 9. Become a good actor or actress. Learn how to play it off. When someone comes up to you that you've never met and acts as if you two are good friends, these people may be strangers to you, but could be best friends with one of your alters. You simply do not know because you did not have co-consciousness during the interaction with that person. So become a good actor and/or actress when this occurs. Use your judgment with this one. I mean, you know a creeper when you see one, right? There's a difference. Just be careful. Dissociative identity disorder, a gift with a future. The official name for multiple personalities is dissociative identity disorder, or DID. Some would like to change the label to dissociative identity experience, but the initials DIE won't work quite as well. Still, DID is less a disorder than a model for describing how some people experience the world and develop coping skills in extremely difficult situations. This write-up is meant only as an introduction to the topic. If you feel you or a family member needs more information, please seek further resources or contact a mental health professional. We all disassociate or disconnect in some ways, driving home safely yet not remembering the trip, consciously placing your keys in one place with no recollection of where a half hour later, or maybe listening but not hearing what someone said for the last few minutes. Maybe you've been embarrassed and even surprised because you reacted in a childish way to a situation. Sometimes after an accident, we cannot remember what happened, as if the whole incident is carefully encapsulated in a memory vault. Other times, we may be experiencing emotional or physical pain and feel like we are stepping outside our bodies and watching from afar. Sometimes, if we are very frightened, time seems to slow down, as if we are part of a film in slow motion. The brain is amazing in the variety of ways it will allow us to multitask, deal with difficult memories, and cope with present danger. We block out memories, revert to old habits, or find ourselves drifting far away from the task at hand. Take these attributes and add the imagination of a child, and you have the ingredients, present in all of us, to create multiple personalities, or parts. The catalyst is repeated abuse that was experienced or witnessed by the child. When the child frequently feels terror, helplessness, powerlessness, and perhaps physical pain, and nobody will rescue them, then the child has to do something to survive. Let's pretend becomes a very handy tool. Have you been in a boring meeting and pretend you are lying on the beach? The child says, let's pretend this is not happening to me but to someone else, and she creates another part with its own name to take the abuse or handle the terror. Soon, it becomes a coping skill to create a holding place for the bad memories, physical pain, and intense feelings anytime there is difficult trouble in her life. Creating a part is also a survival tool. Perhaps a powerful anger starts to develop towards the abuser. It is too dangerous to express that anger as it might cause more punishment, so the child creates an angry friend, maybe even a little older, who can watch and wait for a time to act. Maybe she realizes that when she is very, very good, there is peace in the family, so she creates a little one who is obsessed with perfection. Or maybe there are times when she feels happy, but she is concerned that she doesn't deserve happiness. To her child's mind, it seems that she must be very bad to be so mistreated. So she creates a playmate that loves to skateboard and is always watching the other kids for the latest moves. This system of helpers works well for the child, but as an adult, there may be some surprising results. An adult might find they become very frightened for no reason, perhaps even having panic attacks. They might notice there are memory gaps or time loss, or sometimes a feeling of disorientation. Who am I? How old am I? What have I been doing all day? Why do I have a talent one day and then am unable to perform the next day? There may be times when family or friends seem momentarily unfamiliar, or times when others are surprised at their capacity to tolerate physical pain. These are only a few of the ways that might indicate there is some identity confusion from unresolved childhood trauma. Dissociation identity disorder begins in childhood as a result of trauma and abuse. It is a gift of survival and coping that stays with the adult and reappears in unhelpful ways under times of stress. If you sense that this may be true for you, seek out help from a mental health professional who specializes in this area. Life and relationships can be better. Treatment includes an understanding of what is happening and realizing you are not crazy. New and healthier coping skills are taught to blend with those learned in childhood. Dissociative disorders, Ayurvedic herbal treatment. People affected with dissociative disorders chronically escape their reality in involuntary unhealthy ways, ranging from suppressing memories to assuming alternate identities. There are 4 major dissociative disorders: dissociative amnesia, dissociative identity disorder, dissociative fugue, and depersonalization disorder. Common symptoms include memory loss of certain time periods, events, and people, mental health problems, depersonalization, derealization, and a blurred sense of identity. Dissociative disorders usually develop as a mechanism for coping with trauma. Treatment for dissociative disorders may include psychotherapy, hypnosis, and medication. Creative art therapy and cognitive therapy may also help in treating this condition. The Ayurvedic treatment of dissociative disorder is aimed at treating the basic cause of this condition and preventing complications like depression, anxiety, eating disorders, severe headaches, sleep disorders, alcoholism, substance abuse, sexual dysfunction, self-mutilation, and suicide attempts. Medicines like Sarpaganda Rauwolfia serpentina, Brahmi Bacopa monnieri, Shankpushpi Convolvulus pluricalis, Vaka Acorus calamus, Manduk parni, Centella asiatica, Jadamancies, Nardistachys jadamancy, Brahmi vati, Hirasani ova, Hyoscyamus niger, Brahmi grut, Unmad Gayasari, Sut Shekhar, and Mahavat Vidvans are used in high dose to treat anxiety, depression, sleep disorders, and the original dissociative disorder. An addition of Savarna Basma, Abarak Basma, Trivang Basma, and Lakshmi Vilas Ras to the above-mentioned medicines helps in increasing the therapeutic response. Different Panchkarma procedures can be used to treat patients with dissociative disorders. A whole-body massage is done using medicated oils like Maharayan oil, Mahamash oil, and Mahasandhav oil. The patient is asked to consume regularly medicated ghees like Brahmi Groot, Panchgava Groot, and Kalayank Groot in high doses. These two procedures comprise the Sneha therapy. Medicated enemas are given using Dashmul Gada and Sahacha oil. Nasha therapy is done using medicated nose drops like Vaka oil, Marich, Piper nigrum, and Gud Sunthi. The third combined procedures of Nasha, Snehan, and medicated enemas initially have only a physical effect. However, on being repeated periodically, they help to control the Vata dosha and gradually help in controlling the dissociative features. Shirobasti or Shirodhara procedures may be used temporarily to sedate highly excited or disturbed patients. Patients affected with dissociative disorder should be in regular touch with a psychiatrist and a counselor. They should establish a family and friend support system. Although the course of therapy can be difficult, many people with dissociative disorders are able to learn new ways of coping and lead healthy, productive lives. Healing multiple personality disorder through the power of the mind. We disassociate sometimes and find ourselves forgetting where we have last placed our belongings. We might even fail to recognize our reflections in the mirror and lose our way home. These disassociations, however, can be considered normal and can simply be caused by stress and fatigue. But when we don't just forget things, but also start hearing voices, or feeling that our bodies are not our own, or waking up in unfamiliar places, we might be developing a case of multiple personality disorder. Multiple personality disorder is more commonly known today as dissociative identity disorder. People with it are usually seen as having two or more alternative personalities and may have different ways of speaking and relating to others. MPD is deemed to result from an individual's coping strategy with intolerable trauma like childhood sexual or physical abuse. The intensity of the trauma would cause upsetting memories and emotions in the person, pushing him to frequent a made-up fantasy world where he could forget his horrors and detach himself from his pain. A person with MPD then can be seen as living through his mind. Because MPD is a restructuring of the personality to help the person mentally cope with trauma, then the disorder can also be healed through the power of the mind. Clinically, MPD can be treated by way of integrating all the alternate personalities of the individual. In most cases, the integration calls for the use of systems contract with the alternates. Here, the alternate personalities are recognized by the therapist as separate people who have the right to be heard, but are also expected to respect the host personality and the therapist. One alternate is not allowed to do things on his own without the consent of another alternate. When not all alternates are fluent with the expressing themselves, they are allowed to use other mediums such as journals, toys, and computers. Integration sometimes goes beyond system contracts in order to heal the person. For instance, it may be incorporated in cognitive therapy, wherein the person is put in a calm disposition, allowing the therapist to call the alternates and negotiate with them. Soon the person realizes that all alternates are only part of his fantasized personalities used to cope with his experiences. The realization changes the mind, thereby creating changes in the person. Visualizations, as part of mind power and cognitive hypnotherapy, enables the person to see himself healing from his pain, and later experiencing the actual healing process. Putting his mind into the healing process helps him retune his mentality from only encapsulating the pain to reliving good and painless memories. In this manner, an amount of change is felt all throughout the person. When healing throughout the mind is done, a sense of unity is usually felt by the person, and he no longer hears other voices or acts in inconsistent behaviors. The person thus returns to his real self, healed and able-bodied. How is multiple personality disorder diagnosed? Multiple personality disorder is a mental disorder that has been renamed dissociative identity disorder. The name change took place because there is a high degree of dissociative behavior attached to this disorder. There is no definitive test for this disorder. It is diagnosed after a number of specialized and specific screening tools are used. Trained mental health specialists conduct specialized tests to rule out any other mental disorder that could explain the symptoms or signs that the patient is experiencing. This diagnosis takes time. Most people who are eventually diagnosed with dissociative identity disorder, or DID, have usually been seeking treatment in the mental health system for several years. Dissociative identity disorder usually coexists with other emotional conditions, including post-traumatic stress disorder, borderline personality disorder, as well as other personality disorders. Oftentimes, a person will feign having a multiple personality disorder because of involvement in the criminal justice system, and it would be to their advantage to have this diagnosis. A structured interview tool is often the best way to find the person who actually does suffer from this condition. Most people diagnosed with dissociative identity disorder are usually between the age of 20 and 40. They are likely to have been hospitalized several times, as well as diagnosed with manic depression or schizophrenia. There are a number of criteria that must be met before diagnosis. 2 or more distinct identities must present themselves, each with its own pattern of interpreting and thinking about the environment and self. At least 2 of these identities recurrently take control of the person's behavior. The person is unable to recall important personal information that is too important and extensive for regular forgetfulness. The symptoms are not due to the direct effect of a substance, legal or illegal, or to a general medical condition such as epilepsy. The assessment process includes a detailed history of the person's childhood and other mental conditions. The tester will also ask for a complete physical examination by a medical doctor to rule out any physical disorders. After elimination of any physical illness, the doctor next rules out psychotic disturbances. If the doctor still suspects DID, a screening test called the Dissociative Experiences Scale is used, followed by specific additional testing. It takes an expert to diagnose this disorder. The diagnosis takes time because of the extensive history and testing involved. There still is much controversy over whether this disorder actually exists. Multiple personality disorder and addictions. Multiple personality disorder, or MPD, renamed dissociative identity disorder, or DID, is a very complex and controversial diagnosis to attach to someone. The likes of Sybil come to mind when people think of MPD. A much milder version is more often the norm than the crazy, out-of-control patient often depicted by Hollywood. It is common to have 5 to 25 different personalities. The official psychiatric diagnosis criteria for DID, according to the DSM-4 TR, include the presence of 2 or more distinct identities or personality states. At least 2 of these identities recurrently take control of the person's behavior, and the inability to recall important personal information that is too extensive to be explained by ordinary forgetfulness. Family and friends report. Family and friends of a DID may report the patient has frequent gaps in memory, personal, both past and recent. Reports of finding items of clothing at home that the individual cannot remember having, and not remember a whole segment of the day as to where they were or what they were doing. Misplacing keys, wallets, purses, and cars in parking lots is common. Misdiagnosed for years. Quite often, the DID patient would be described as Dr. Jekyll and Mr. Hyde, meaning one moment the person may seem very passive and submissive, and then suddenly an impatient, controlling, and/or self-destructive person emerges. It is very common that a person with DID will be misdiagnosed for 6 to 7 years before the dissociative identities are correctly identified. Usually, the misdiagnosis given is bipolar disorder or borderline personality disorder. Personalities out of touch with others. Each personality state may be experienced as if it has a distinct personal history, self-image, and identity, including different names. I've had clients where one personality will write left-handed with beautiful handwriting, while the other personality will insist he or she can only use the right hand to write. To be talking to an adult one minute and a young rebellious adolescent another is fairly common. Enormous problems for an addict. There is no doubt that DID is a mysterious disorder, one that needs attention and extensive counseling to resolve. Having one of many personalities, that is an addict, creates enormous problems in overcoming the addictions, because until that addiction personality is integrated, becomes whole, to the host, he or she will always have the alternative to escape real or perceived danger with drugs and or alcohol. Why use drugs or alcohol? This is really a simple one to explain. Just like bipolar disorder, borderline personality disorder, hyperattention deficit disorder, and just about any type of disorder can cross over into addictions because people strive to feel normal. I have had many clients who are addicts that do have multiple personality disorder. With alcohol, drugs, gambling, sex, and any kind of addiction, there are those who will do anything to feel normal. Whether to not feel the pain of shame or to settle the chaos inside, people choose every day to medicate in an effort to distract, avoid, or to deny their life struggles. Potential blocks in the therapy process for clients with dissociative identity disorder. The healing process for dissociative identity disorder, DID or MPD, is very long, involved, and complex. It takes years of time to work through all the issues and complications created from severe trauma and dissociative splitting. And while that length of time may feel discouraging in the beginning, let me assure you that progress truly is possible. You really can heal from your hurt and traumas and lead productive, happy, healthy lives. Therapy is somewhat like the progression through years of school. Therapy work builds upon itself through time to involve a lot of additional steps, the basics needing to be accomplished and mastered first. If the basics are neglected or not learned well, then therapy will get stuck. And if someone goes to school and gets stuck in the 5th grade for 3 years, they're going to feel very frustrated, especially if the goal is to graduate from high school. So what keeps a person stuck and unable to progress further in their healing? What blocks their therapy from moving forward? Sometimes people get comfortable addressing only the surface layers of their trauma. Sometimes they get too afraid to address the deeper layers of their system. Therapeutic resistance can be normal for various periods of time, but will avoiding these areas of your healing bring you the peace of mind that you want? What if you have been in therapy for years already and are still struggling desperately? Blocks and stalemates in the therapy process usually lead to increased depression, ongoing anxiety, more self-injury, not to mention the added frustration and wasted time and resources. While it is important to tackle the healing process at your own pace, it is also good to make significant treatment gains at every step of the way. What is missing in your therapy healing process? What is interfering with your therapy process? Where are you resistant to change? Here are some of the common reasons that people get stuck in their healing process. Current day abusers actively sabotaging the progress you are making in therapy. Current day control by external abusers reinforcing the fear of telling. External life issues become too overwhelming, i.e. kids, school, work, finances. Fatigue, frustration, and just being tired of trauma issues being the center of your life. Fear of learning more or future consequences of any number of things. Fear of other loved ones being hurt or abused if certain secrets are exposed. Finger pointing, blame at others instead of being self-responsible for movement and changes. Generally incompetent therapy or working with an uninformed therapist. Interference of addictions, any form of drug abuse, alcohol abuse, sex addiction, etc. Internal programming is running interference and not being removed or addressed. Laziness, thinking that healing happens magically without having to put in the hard work required. Not really and truly wanting to do the therapy work, simply going through the emotions instead. Outgrowing the therapeutic knowledge and assistance that your current therapist can offer. Putting more effort into helping and rescuing others than addressing personal issues. Refusal to speak with the others in your system. Refusing to acknowledge, admit, or address your own negative behavior. Sabotage of self, of relationships, of therapy. Self-injury, self-destructive behavior, suicidal behavior, the front host refusing to speak with the inside system. Treatment issues for dissociative identity disorder. How long will it take for me to feel better? Dissociative identity disorder is a result of long-term, chronic, severe, sadistic child abuse. As children, these survivors witness and experience a myriad of heinous crimes. They typically describe repeated consuming abuse by multiple predators, and then were otherwise emotionally neglected, starving for comfort, consolation, or attention. They were left alone even while very young to process and contain their pain by themselves. For these children, the splitting process became their way of coping with emotional intensity, conflicts, huge distress, and intense pain that were otherwise far too difficult to manage on their own. They blocked off their pain, locked it away from themselves, and left it there, sitting, waiting, piling up for years. When you understand how much pain and abuse has occurred in order to create the dissociative splits in the first place, it is no wonder that the healing process is also so very long. All areas of dissociative survivors' lives are touched and profoundly changed or affected by the abuse. It simply takes a very long time to address everything properly. Some of the treatment issues are creating emotional separation from external predators, working with triggers, correcting cognitive distortions, addressing gender confusion, male versus female issues, processing emotions, body image issues, reducing time loss, memory loss, amnesia, time confusion, time distortion, trauma processing and memory work, body memories and kinesthetic issues, understanding reenactments and trauma bonds, healing sexual abuse issues, healing physical abuse issues, healing emotional abuse issues, healing ritualized abuse issues, healing exploitation, pornography, prostitution, sex slavery issues, managing family, material, parenting issues, addressing addictions, managing eating disorders, household management issues, improving daily functioning, relationship issues and teaching social skills, understanding the effects of trauma on the brain, improving self-independence and self-reliance, improving self-esteem issues, leaving disability and regaining employment, depression and medication management, bipolar disorder and medication management, anxiety, panic, and medication management, post-traumatic stress issues, PTSD. That's a tremendous amount of work, and most of these issues surface again and again and again, requiring in-depth attention on a regular basis for years of time. Emotional healing on such a wide scale just does not happen fast. Forcing the issues or pretending to be done sooner than realistically possible is not helpful. Simply put, years of severe injuries will require years of intensive healing. It takes as long as it takes. Treatments and drugs for dissociative identity disorder, or DID. Treatment of DID is difficult for a variety of reasons. Some of the reasons are secrecy on the client's part, making him or her reluctant to seek help, including the difficulty in diagnosing the disorder once the client presents. Typically, an individual with DID will require many years of treatment. Generally, a DID patient will need to be given several different treatment methods over a period of 5 to 7 years, or maybe more. Some of the treatments offered to a DID patient may include psychotherapy. Psychotherapy is the primary treatment for dissociative disorders. This form of therapy, also known as talk therapy, counseling, or psychosocial therapy, involves talking about the disorder with a mental health professional. The therapist will help patients remember and work through the trauma that triggered the dissociative symptoms. The course of the psychotherapy may be long and painful, but this treatment approach can be effective in the treatment of DID. Creative art therapy. This therapy uses the creative process to help people who might have difficulty expressing their thoughts and feelings. Creative art therapy includes art, dance and movement, drama, music and poetry. Things such as keeping a journal or creating art is also encouraged during treatment to help bring the past and present together. Medications. Although there are no medications that specifically treat dissociative disorders, medications like antidepressants or tranquilizers are a very common treatment method because the personalities may have anxiety or mood disorders, and the medications may help control the mental health symptoms associated with the disorders. Generally, medications are not recommended because maintenance of the effective use of prescriptions given to multiple personality states is difficult to attain. If medication is prescribed, it should be carefully monitored. Alternative medicines. The therapist may recommend using hypnosis as part of the treatment for a dissociative disorder. Hypnosis creates a state of deep relaxation and quiets the mind. In hypnosis state, the patient can concentrate on a specific thought, memory, feeling, or sensation while blocking out distractions. Hypnosis is also perceived to be an effective treatment to uncover painful repressed memories or even to help stop behaviors carried out by alters, such as self-manipulation or eating disorders. Hypnosis is also used in the fusing process. Hypnosis is generally safe as a complementary treatment method. Some doctors also believe in botanical medicine, massage, and yoga as effective treatments. Self-help. Online self-help groups are a growing trend, and individuals with DID are beginning to form online self-help support groups in addition to the traditional in-person self-help groups. Why do some people have split personalities? This disorder usually begins in childhood as a defense against prolonged trauma, usually some kind of abuse, either mental or physical. The theory is that the mind splits in two, so that it can retreat into the other personality or personalities in times of extreme distress, and to allow the newly created part to take some of the burden of distress by sharing the pain. Another explanation, and this seems more likely, could be that the mind is creating an untouched personality, knowing that the original one has been severely corrupted. Much like when we partition a hard drive, in case one part becomes corrupted, then we still have the other clean partition to work with. And the reason each part knows nothing of the other and its experiences could be to protect it from the corruption and disorder of the abused part in order for that newly created part to function properly. If the new part had any memory or knowledge of the abuse the other went through, it would become damaged. How do these dramatic physical changes happen? If the mind and body are linked as closely as this suggests, then it would seem that the memory, experiences, and beliefs of the person are linked to every cell in the body, so that when the person changes personality, all previous beliefs and so on are completely erased from the duration, therefore changing the whole biology, molecular structure, cell structure, and chemistry of the body according to the new part. So what does this all mean, and how can it help us? This is showing us how powerful the human mind is, and that our bodies and their ailments, both mental and physical, are not permanent, but can be changed by the power of belief and thought. If we believe something without doubt, surely we can affect our own bodies at the cellular level, just as people unconsciously do with multiple personalities. We could just imagine that we are healed and it would happen. We could see in our mind that the cancer has gone, and it would be done. Disease of every kind would be a thing of the past. All we need is the unwavering belief of our inner power. And the seemingly strange things that occur with people with multiple personalities should give us this belief. There are many ways we can utilize this mind power. Through hypnosis, we can gain access to the subconscious to create new beliefs using visualization and other transformation techniques. Hypnosis is well known to be able to create the same phenomena described in this article in emotionally normal people. Even without formal hypnosis, a person can learn powerful visualization techniques, which, if vivid enough, can be very powerful. Visualization works because the mind cannot differentiate between mental images and real images. So if we see something vividly enough and for long enough, the body's cell structures will begin to conform to what is being seen in the mind. Just like when a multiple personality takes over from a previous one, his cell structure and mental state is changed according to the beliefs of the new part. Narcolepsy. Neurological lessons about narcoleptic disorder Solutions, Prevention Methods, and Treatments. Written by Quinn Spencer. Narrated by Eric Boozer. Definition of narcolepsy. Narcolepsy is classified as a chronic sleep disorder and is considered a chronic neurological disorder that is caused by the inability of an individual's brain to regulate sleep-wake cycles properly. An individual suffering with narcolepsy experiences daytime sleepiness and uncontrollable bouts of falling asleep during the day. Individuals suffering from narcolepsy are unable to stay awake for long periods of time, and sufferers fall asleep at an inappropriate place or time, sometimes without warning. Other much more severe symptoms experienced by an individual with narcolepsy include a condition called cataplexy, which is a sudden loss of muscle tone that can cause physical changes such as slurred speech or muscle weakness. Cataplexy is often triggered by intense emotions and is uncontrollable. Another condition that may occur for individuals suffering from narcolepsy is sleep paralysis, where the individual temporarily is unable to speak or move while falling asleep or waking. Individuals with narcolepsy also suffer from hypnagogic hallucinations, which are dreamlike auditory or visual hallucinations experienced when an individual is dozing or falling asleep. A typical sleep-wake cycle for a person without narcolepsy is early stage of sleep, deeper stage of sleep, and then after approximately 90 minutes, REM, or rapid eye movement sleep. For an individual suffering from narcolepsy, the REM sleep stage occurs almost immediately after they fall asleep, as well as periodically during their waking hours. This disease can affect an individual at any age, but usually occurs between the ages of 15 and 25. It is also more common in men than women. It is a very underdiagnosed illness, often thought to be depression, epilepsy, or a side effect of medication. Many individuals suffering from narcolepsy are never properly diagnosed, though the disease is very disabling to their life. It can impair an individual's work, social life, personal relationships, and make them more prone to accidents. The cause of this disease is not known. However, it is believed that genetics play an important factor. A small percent of individuals suffering from this sleeping disorder have a close relative that also suffers from the disease. An individual should seek medical advice if they experience excessive sleepiness during the daytime, excessive to the point where it interrupts their personal and/or professional life. The medical doctor will likely refer the individual to a sleep specialist who will diagnose the main issue and determine its severity. Diagnosis can consist of a review of the individual's sleep history, a polysomnogram, test that measures sleep signals through electrodes on the scalp, and a multiple sleep latency test which measures how long it takes an individual to fall asleep during the day. Both the polysomnogram and multiple sleep latency tests are conducted in a medical facility or a sleep clinic. There is also no cure for this sleeping disorder, but there is treatment. Treatment depends on the actual severity of the individual's narcolepsy, which is determined by testing. Treatment is tailored to the individual and can consist of lifestyle adjustments, such as the regulation of sleep schedule, scheduling of daytime naps, avoiding caffeine or alcohol, establishing an exercise routine, and a meal schedule to help reduce the symptoms. A doctor may also try drug therapy by prescribing a stimulant drug that helps keep the individual suffering from narcolepsy awake during the day, or an antidepressant drug that suppresses the REM sleep cycle. Causes of narcolepsy. People with narcolepsy disorder always tend to have difficulty to stay awake. They can fall asleep very suddenly during the day. It's like a sleep attacks them. Even after they have enough sleep, they can still easily fall asleep. This unusual sleeping problem is really affecting their social life, work, and everyday life. There are two kinds of sleep, that is non-rapid eye movement and rapid eye movement. For normal people, they will go through the non-rapid eye movement sleep first before rapid eye movement, period. But it's different for people with narcolepsy. They usually go through the rapid eye movement first before the non-rapid eye movement. Because of this, they normally will lose their muscle tone when they wake up. Worse, this muscle tone and loss of control can make them collapse. They also will be getting sleep paralysis. That means they won't be able to speak, or even move, no matter while they were waking up or falling asleep. And when they wake up, they also tend to see hallucinations. According to some research, it was stated that the main cause of narcolepsy is the brain, which are lack of hypocertain chemical that works to stimulate the cells in the brain in order to give wakefulness. The reason for the lack of this hypocertain chemical in people with narcolepsy is still unknown. However, there are some factors that were known to be the causes of the lack of hypocertain, which is stress and brain injury. If there's a brain injury, there will be some loss of certain brain cells. Other factors are infected, and also changes of hormones. Nevertheless, it was also found that few numbers of people with narcolepsy has related to their relatives also with narcolepsy, meaning some people inherited the tendency of having narcolepsy disorder from their relatives. Regarding the inheritance of narcolepsy, research has been made and it has been identified that gene also causes narcolepsy. Hypothalamus is a part of the brain that stimulates sleep behavior, and the gene will give away to the cells in hypothalamus to get messages from other cells in the brain. However, if the gene is not normal, those cells won't be able to connect and communicate normally, and this is why the abnormality of the sleeping patterns occur. It does run in the family for some people, but most of them with narcolepsy, they don't relate to any of their relatives that suffer the same disorder. In conclusion, it doesn't mean that if you don't have any relatives with narcolepsy, you won't get it. Ayurvedic herbal treatment. Narcolepsy is a chronic sleep disorder characterized by overwhelming daytime drowsiness and sudden attacks of sleep, which may cause serious disruptions in daily life. Common signs and symptoms include excessive daytime sleepiness, sudden loss of muscle tone, sleep paralysis, hallucinations, automatic behavior, and restless, nighttime sleep. Genetics and a disturbed immunity are the known causes for this condition. The Ayurvedic treatment of narcolepsy is aimed at increasing nighttime sleep and reducing daytime bouts of sleepiness. A combination of sedatives and stimulants are used for this purpose. Medicines like Brahmivati, Saraswatrishta, Lakshmi Vilas Ras, Mahalakshmi Vilas Ras, Dashmularista, Arjunarista, Mahavat Ras, Makar Dwa Ras, Abrak Bhashma, Savarna Bhashma, and Brat Vat Chintamani are used for this purpose. Herbal medicines which can be used in this condition are Brahmi, or Boka Manari, Jatamansi, or Nordostachys jatamansi, Sarpaganda, or Rawolfia serpentina, Mendukbarni, or Centella asiatica, Shankpushpi, or Convolvulus pluricalis, Vacha, or Acorus calamus, Guduchi, or Tinospora cordifiola, Tegar, or Valeriana wallichi, Negrondi, or Vitex negundo, Vishwa, or Zinziber officialis, Marich, or Piper nigrum, Pipali, or Piper longum, Chitrak, or Plumbago zelansia, Shavia, or Piper rectrofractum, Huchla, or Staichunos nox vomica, Ashwangda, or Withania somnifera, Rasna, or Pluchia lanceolata, Arundmul, or Ricinus communis, Shalparni, or Desmodium gangecticum, and Pushnaparni, or Uraria picta. It is important to note that treatment has to be tailor-made for each individual patient, and modifications made in therapy after receiving feedback from the patient. Several Panchkarma procedures can be put to good use in the treatment of narcolepsy. In the procedure Snohan, the entire body is massaged with medicated oils like Maharayan oil, Mahamash oil, Chandan, Bala Lakshmi oil, and oil of sesame. This is followed by Sweden, in which steam fomentation is given to the entire body using medicines like Dashmul Kata and Nigrundai Kata. Nausea therapy can be done in this condition, which consists of instilling nasal drops like vacha oil, maric oil, and liquid extracts of shingru, Magoria oleifera, and Vishwa, Zinzibar officinalis. Medicated enemas can also be given using medicines like Vishgarbaha oil. The therapeutic purpose of all the above-mentioned Panchkarma procedures is to reduce the kapha dosha or regulate the vata dosha. This in turn reduces excessive daytime drowsiness and sleep attacks. With adequate medications and appropriate lifestyle modifications, most patients of narcolepsy can suitably adapt to their condition. People affected by this condition should avoid long drives, nicotine and alcohol. They should exercise regularly, follow a fixed daytime schedule, take frequent naps, and take into confidence their friends and colleagues regarding their affliction. Dietary management for narcolepsy. Avoid alcohol and sugar. Avoid stimulants like coffee, caffeinated drinks, tea, or drugs. Make a schedule and maintain time of sleep. Avoid shift work to maintain timing of the shift. Take short naps during the day. Schedule naps like 15-minute nap after lunch, then 15-minute nap at 5:30 p.m. This will provide temporary alertness and reduce the intensity of daytime sleepiness. Consume. Reduce intake of fats. Increase intake of omega-3 fatty acids. It protects the cell membranes and the myelin sheath of the nerves. Increase intake of fiber. Increase intake of calcium and magnesium needed for energy production and proper functioning of nervous system. Consume food high in protein diet during the day. Protein foods increases alertness. Consume foods that contain all essential amino acids. Food high in proteins contain L-glutamine or amino acid. It promotes mental ability and is a brain fuel as it passes the brain barrier freely. You can take L-glutamine supplements, empty stomach with water or juice. Do not drink milk with it as it hinders the absorption. You can have vitamin C and vitamin B6 supplements along with it for better absorption. Consume proteins high in L-tyrosine. It is needed in production of norepinephrine and dopamine, which are important for mental alertness and long-term memory. Consume foods high in L-tryptophan in the evening meals with carbohydrates as they slow mental function and cause sleepiness. Milk, tuna fish, turkey and eggs, almonds, cabbage, kidney beans, oats, pistachios, bananas, poppy seeds, pumpkin seeds, spinach, wheat, sunflower seeds, and evening primrose seeds. Consume complex carbohydrates for evening meals as they have calming effect and may endorse sleepiness. Even though carbohydrate calms brain but is necessary for adequate mental performance as glucose is main fuel source for brain. Consume food high in choline or lecithin. Choline acts as a neurotransmitter and is very important for brain function. Milk, eggs, liver, wheat germ, and peanuts are rich in choline. Other sources are beef, shrimp, salmon, Atlantic cod, Brussels sprouts, broccoli, and milk chocolate. Consume foods high in chromium. It promotes energy and regulates sugar metabolism. Consume coenzyme Q10. It increases circulation to the brain. Food sources: meat, poultry, fish, soybean, canola oil and nuts, fruits, vegetables, eggs, dairy products are also good sources. You can take supplements of coenzyme Q10, 100 to 300 milligrams per day. Consume octocosanol supplements. It is a naturally occurring substance found in sugarcane, wheat germ oil, spinach, and other natural food sources. It increases the oxygen utilization by the body. Consume B vitamins, especially niacin and pyridoxine. B vitamins boost metabolism and increase the energy levels and normal brain functions. Consume food high in pyridoxine. Consume food high in niacin. Consume lots of vitamin C and bioflavonoids. Increases energy and has antioxidant properties. Eat fresh and raw fruits and vegetables as they provide antioxidant and flavonoids which help in reducing inflammation and boosting up immunity. Consume foods rich in vitamin E, increases circulation and protects brain cells. Increase intake of vitamin D. Vitamins and minerals for narcolepsy. Vitamins and minerals recommended for narcoleptic patients are omega-3 fatty acid. Membranes of cells in the human body are made of unique fatty acids. Disruption of their function affects synthesis and secretion of neurotransmitters. Omega-3 fatty acid is important to maintain the integrity of cell membranes. Lecithin and L-glutamine enhances mental stability and alertness. Vitamins B, C, E, and K are essential antioxidants and immune system modulators. Choline is a substrate in the synthesis of acetylcholine. It is a neurotransmitter that plays a role in sleep-wake cycles. Magnesium, selenium, and chromium picolinate improves blood supply to the brain and enhances oxygen utilization by the brain. Discover the best treatment for narcolepsy. Treatment for narcolepsy. As far as treatment for narcolepsy goes, medication and changes to one's lifestyle can control the symptoms of the disorder. Narcolepsy, however, cannot be cured completely using medication. The most undesirable symptoms of the disorder, which include cataplexy and EDS, can be arrested. Stimulants. In order to help people with narcolepsy stay awake and alert during the day, stimulants like modafinil, or Provigil, or methylphenidate, or Ritalin, are used. The former is a relatively new medication used as a treatment for narcolepsy symptoms, as is also less addictive than older stimulants. The latter has been around for a long period and, like other older stimulants, can sometimes produce side effects like palpitation and nervousness. Modafinil as a treatment for narcolepsy. Currently, modafinil is the superior narcolepsy treatment for many reasons. It's not addictive, it doesn't create euphoria or a high, it has a long half-life of 12 to 15 hours. This means you just take one dose in the morning. It doesn't burn the brain out, and users can discontinue and feel normal immediately. It's cheap because lower doses are needed less often. There is no opportunity for abuse potential, unlike dexamphetamine, which has a massive abuse potential. So as you can see, it's light years ahead of any other narcoleptic treatment. Antidepressants. Antidepressants are used as a treatment for narcolepsy symptoms like cataplexy or sleep paralysis, which are associated with REM sleep. These medications aim to suppress REM sleep and thereby alleviate the symptoms associated with it. They also help prevent hypnagogic hallucinations that people suffering from narcolepsy might have. Antidepressants administered for this condition include imipramine or trofinil and protriptyline or Vivactil, fluoxetine or Prozac and Serafim, and Sterline or Zoloft, which are serotonin reuptake inhibitors or SSRIs, are also used as antidepressants. Sodium oxybate or Xerum is also another drug that helps in controlling cataplexy. It also helps people suffering from narcolepsy get better sleep during the night. When the dosage is increased, it also reduces drowsiness during the daytime. The drug, however, is known to produce side effects like bedwetting, sleepwalking, and breathlessness, which has prompted the FDA to regulate the drug very strictly. Lifestyle adjustments are also a natural and effective form of treatment for narcolepsy. People can avoid heavy meals, alcohol, or caffeine before going to bed. They also need to follow a strict bedtime schedule. They can have short 10 to 15-minute naps during the day to manage sleepiness. Maintaining a healthy diet, having good exercise for the body, and living a healthy lifestyle would drastically reduce the symptoms of narcolepsy. History of narcolepsy. The first convincing descriptions of narcolepsy cataplexy were reported in Germany by Westphal, 1877, and Fischer, 1878. The unique association of episodes of muscle weakness triggered by excitement and sleepiness were described in these two reports. In both cases, hereditary factors were noted, with the mother of Westphal's patient and one sister of Fischer's patient presenting narcolepsy symptoms. The leading hypothesis to explain narcolepsy at the time was to refer to the well-publicized case of von Zastrow. Von Zastrow was a recently arrested pathological rapist, widely believed to experience pathological sleepiness as a result of repressed homosexuality and excessive masturbation. Glenot, 1880, is widely recognized for giving narcolepsy its name and for recognizing the disorder as a specific clinical entity. Its description of a wine cask maker with narcolepsy in La Gazette des Hospitaux de Paris was classical, but Glenot did not strictly differentiate muscle weakness episodes and sleep attacks triggered by emotions. Rather, Glenot suggested a common physiology for these two symptoms. Lowenfeld, 1902, was the first to give a name to muscle weakness episodes triggered by emotions or cataplexy. In 1917 through 1927, epidemic of encephalitis lethargia led to a renewed interest in narcolepsy and sleep research, but also added much confusion to the nosological definition of narcolepsy. Encephalitis lethargia often presented initially with somnolence, and the term narcolepsy was often used to describe any form of daytime sleepiness. The association of somnolence and oculomotor paralysis also led to the pioneer work of von Economo, 1930, and the recognition of the posterior hypothalamus as a critical region for the promotion of wakefulness. In fact, von Economo should be credited as being one of the first investigators to correctly propose that a region in the posterior hypothalamus was lesioned in human narcolepsy. In 1930 he wrote, "It is very probable, though not proved, that the narcolepsy of Gilleneuve, Westphal, and Redlich has its primary cause in a yet unknown disease of that region." As narcolepsy with cataplexy was also observed in some cases of encephalitis lethargia, clinicians long debated the existence of idiopathic narcolepsy and the importance of cataplexy for defining the clinical entity. Large case series of narcolepsy cataplexy were reported by Addy, 1926, Wilson, 1927, and Daniels, 1934. The review by Daniels is considered by many as one of the most insightful clinical reviews published to this date. Further work at the Mayo Clinic by Yoss and Daly and in Prague by Bedrich Roth then led to the classic description of the narcolepsy tetrad. Various methods were initially proposed in the treatment of narcolepsy, including intrathecal injection of air, cerebrospinal fluid removal, and X-ray irradiation of the hypothalamic region. Ephedrine treatment was generally used as the only marginally effective treatment for daytime sleepiness until Prinz Metal and Bloomberg introduced amphetamines in 1935. Yoss and Daly introduced methylphenidate in the 1960s. Shortly after the discovery of tricyclic antidepressants in 1957, Akimoto, Honda, and Takahashi used imipramine in the treatment of human cataplexy, establishing the dual stimulant antidepressant pharmacological treatment most commonly used in narcoleptic patients to this date. Narcolepsy and its relationship with REM sleep. The early descriptions of REM sleep and its associated atonia led multiple investigators to study sleep onset in narcolepsy. Vogel, 1960, was the first to report REM sleep at sleep onset in a narcoleptic patient, an observation extended by Rechtschaffen and Dement a few years later. Together with Hishikawa, who studied the EEG of narcoleptic subjects during sleep paralysis and hypnagogic hallucinations, these authors articulated the now classical hypotheses of dissociated REM sleep to explain some of the symptoms of narcolepsy. This discovery also led to the establishment of the multiple sleep latency tests as a standard diagnostic test for narcolepsy. In spite of this progress, the early post-war period was fraught with psychoanalytical explanations for narcolepsy cataplexy, together with Kleitman, who believed narcolepsy was an organic disorder involving abnormal carotid stimulation reflexes. Daniels was among the few to believe in the organic nature of narcolepsy. In a letter to Kleitman dated July 21, 1948, Daniels wrote, "I was particularly interested in your views regarding the significance of narcolepsy, because I came to the same conclusion early in the course of my studies and have been decidedly annoyed by the recent attempts of the psychosomaticists to revive the old idea that narcolepsy is simply a form of escape. Narcolepsy diagnosis criteria: narcolepsy and cataplexy. If you feel excessively tired during the day, you can use the narcolepsy diagnosis criteria to find out if narcolepsy is likely to be the cause of your problems. Let me explain how the criteria work and how understanding the nature of cataplexy can help you find appropriate treatment. Narcolepsy is a severely underdiagnosed disease. It's thought to affect over 200,000 people in the U.S., but only a quarter of those are diagnosed. This is largely because the severity of narcolepsy varies so much. While it's immediately obvious in some sufferers, others mainly suffer from sleepiness with occasional extra symptoms, which can be difficult to positively diagnose. By understanding narcolepsy diagnosis criteria, you and your physician can decide whether you're likely to be suffering from this condition. Within the International Classification of Sleep Disorders, or ICSD manual, there are two sets of minimal criteria for diagnosing narcolepsy. One of them is narcolepsy when the sufferer has cataplexy. Narcolepsy diagnosis criteria when the sufferer has cataplexy. The first set of criteria is used for diagnosing narcolepsy is if you suffer from cataplexy. Cataplexy is a sudden, unexpected loss of muscle function. This can cause a complete collapse of the body, but might also be less severe and just involve a temporary slacking of facial features, weakness at the neck or knees, or slurred speech. If you suffer from cataplexy as well as lapsing into sleep during the day, most days, that's sufficient to diagnose narcolepsy. But not all cases of narcolepsy include cataplexy, in which additional symptoms need to be observed as well as sleepiness to make a diagnosis. If you experience narcolepsy and cataplexy, being diagnosed with narcolepsy and cataplexy is a common way to be diagnosed with narcolepsy. The good news is there are effective treatments for this condition. Previously, dexamphetamine was used for all narcolepsy treatments. Although it had significant drawbacks in the form of side effects and dependency, for a long time it was the only treatment available. Now there's a new, more superior treatment available in the form of Motivigil. Motivigil, or modafinil, is a new and effective treatment for narcolepsy patients, even if they have cataplexy too. Motivigil has almost no side effects, is cheap, effective, and easy to acquire. See your physician regarding Motivigil as a possible treatment for you or your loved one with narcolepsy and cataplexy. Narcolepsy facts. The primary symptom of narcolepsy is an exaggerated and almost overwhelming sleepiness during the daytime, even after a decent night's sleep. Another symptom is sleep that is often interrupted by frequently waking up. In the most severe cases, people suffering from this sleeping disorder will fall asleep involuntarily at times and places that are inappropriate and can be dangerous as well. These sleep attacks last from just a few seconds to more than 30 minutes. They happen without any warnings whatsoever and make maintaining a normal work schedule or personal relationship very difficult, if not impossible. Narcoleptics lack the vivid separation between wakefulness and sleep that most of us have. Many sufferers have reported that the distinction between being awake and being asleep is often hard to determine. This may be due to the fact that narcoleptics most frequently fall asleep directly into the dream-rich REM state, without gradually progressing through the non-REM stages first. In addition to daytime sleepiness, there are other symptoms as well, but these may or may not be present in all cases. Cataplexy. This is a sudden muscle weakness very similar to the extremity paralysis that occurs naturally during REM sleep. It will last from just a few seconds to several minutes and occurs while the person is awake. Cataplexy seems to be triggered by a quick emotional reaction of some sort, such as laughter, anger, fear, or surprise. This sudden muscle weakness can cause anything from sagging facial muscles to a complete collapse. Sleep paralysis. This is a temporary inability to speak or move when suffering a narcoleptic episode. People with this symptom find themselves not able to move or talk, both when falling asleep and when waking up. Hypnagogic dreams. These are extremely vivid dreams that happen when narcoleptics first fall asleep. Hypnagogic dreams are so realistic they frequently are confused with reality. Sleep researchers estimate that up to 350,000 Americans suffer with narcolepsy, but less than 50,000 have been correctly diagnosed. If this estimation is accurate, these numbers would make narcolepsy more widespread than Parkinson's disease or multiple sclerosis. Narcolepsy is very difficult to diagnose, and especially in those who have only the daytime sleepiness symptom. It is most frequently mistaken for depression or epilepsy, or even the side effects of other medications. Correct diagnosis is most often determined through the use of polysomnogram, overnight sleep recording test, or PSG, and a multiple sleep latency test, or MSLT. Both of these tests will show the signs of falling asleep quickly and directly into REM sleep. When narcolepsy can occur at any time, the symptoms most frequently appear while still in adolescence or very early adulthood. Genetics seem to play a part, as well as 1 in 10 narcoleptics have a close family member who is also narcoleptic. Recent research has revealed that narcoleptics do not seem to have a neurotransmitter called hypocertin, whose job is to ensure wakefulness. The current theory is that perhaps the autoimmune reaction caused by disease, hereditary, or brain injury destroys the cells that manufacture hypocertin, but further research is needed. Narcolepsy in children. Children who suffer from narcolepsy sometimes find it difficult to fall asleep. They feel tired during the day, but still find it difficult to sleep. Narcoleptic attacks can occur at any time. The level of sleepiness is putting your child at risk. No matter what activity your child is conducting, it may experience a narcoleptic attack. Another interesting fact is that children with narcolepsy don't have light sleep. They fall straight to deep sleep. The deep sleep phase in which they directly go to is REM, rapid eye movement. Children with narcolepsy can go to deep sleep at any time when they are awake. In some situations, this can be very harmful for children with narcolepsy. Children with this kind of sleeping disorder find it hard to impossible to stay awake at random moments during the day. Narcolepsy in children isn't a lack of sleep. They might be sleeping the whole night and still be tired the next day. This is what we know as EADS, excessive day sleep. Excessive day sleep is one symptom of narcolepsy in children. When someone falls asleep, they lose control over most of the body's muscles as they are resting. There is a condition in which this happens when they go out of sleep: cataplexy. Cataplexy is similar to sleep paralysis and happens into REM sleep. Some children are experiencing hallucinations when they are waking from a sleep. Hypnopompic hallucinations. Hypnagogic hallucinations is the same, but when falling asleep. These hallucinations can include some other senses as well. Excessive day sleep, cataplexy, sleep paralysis, and hallucinations are all symptoms of narcolepsy in children. Narcolepsy in children is not a night terror. Safe and effective narcolepsy treatment without drugs. Have you been suffering from extreme drowsiness or literally falling asleep even when you don't feel like hitting the sack, or when you're at the office or at the grocery? People diagnosed with this chronic neurological disorder often experience the same symptoms: excessive sleepiness, sleep paralysis, hallucinations, or sometimes cataplexy. Sadly, it has no known cure, and synthetic medications that help to reduce or manage such symptoms pose side effects that could still prove to be debilitating. However, narcolepsy treatment without drugs can also be practiced to help manage the symptoms. Here are some of them. 1. Sleep cycle. Planning short naps, for instance, when done at routine intervals, can help stimulate your system for around 1 to 3 hours according to experts. There are various apps that you can download nowadays to help track sleep cycle, such as Fitbit One, Sleep as Android, Jawbone Up, iOS Sleep Cycle, and Sleepbot. With knowledge harnessed from technology, you can create efficient coping mechanisms and start leading a more normal life. 2. Vitamin supplementation. According to various studies, many patients with narcolepsy are also diagnosed to suffer from vitamin deficiency. Vitamin D deficiency is often connected with pain and fatigue, which, if not treated, can worsen one's situation. Increasing vitamin D via supplementation, such as that of Nature-Wise Vitamin D3, can provide additional 5,000 IU to the body for every capsule popped. Getting direct sunlight for a few minutes also helps. Vitamin B12 via natural supplementation or by consuming vitamin-rich foods can help stimulate the system and counter the symptoms. 3. Sweat it out. Light to moderate exercise can help manage your symptoms, but if possible, do so with a buddy or a personal trainer who understands your condition. Pilates, yoga, and walking are the safest options, as you won't be using equipment that may prove to be risky. A few minutes on a Body Boss Home Gym 2.0, for example, can help rev up your system and reduce other symptoms like brain fog and depression while beefing up your muscle strength and flexibility. 4. Omega-3s. High-quality natural supplement of omega-3 fatty acids is also known to help manage narcoleptic conditions such as ADHD in children. You don't have to worry about its icky aftertaste, as there are burpless natural supplements out there like the Dr. Tobias omega-3 fish oil. A single pop can help improve one's cognitive function and manage other symptoms. It is safe for kids and adults as well as pregnant and lactating women. 5. Talk therapy. Seek out a support group or a therapist. Letting out your frustrations and learning effective coping mechanisms to manage your symptoms can help eliminate negative feelings, acting as stimulant for you to live life to the fullest. One critical point in narcolepsy is depression, as it can lead to various other debilitating symptoms. Striking depression at its core via talk therapy or getting involved in support groups will help greatly in managing the disorder. 6. Elimination diet. Aside from eating foods rich in vitamins and minerals, booting out foods that are known to worsen the condition should be eliminated from your diet. Some of the foods known to possess heavy allergens are chocolate, wheat, soy, alcohol, caffeine, and sugary items. These foods can erratically cause disturbance to your body and worsen symptoms. Consuming a diet rich in fruits and vegetables, low-fat dairy, whole grains, and lean protein is highly recommended. 7. Alternative therapies. Other known, tried and tested therapies used by patients with narcolepsy are acupuncture, massage therapy, acupressure, and meditation can provide positive effects. Aromatherapy using essential oils for massage or for diffusion can help enhance sleep quality and relieve anxiety. Investing in an aromatherapy diffuser like the InnoGear will help. Certain precautions. Narcolepsy has no known cure up to this day. The main idea of narcolepsy treatment without drugs or synthetic medication relies largely on finding natural ways to manage the symptoms and keep a patient safe from risky activities while the disorder strikes. As always, it is best to consult with your physician before diving into self-medication or natural treatment system to ensure safety and sound health, as well as to rule out certain medical conditions and complications that may come with it. The top 9 symptoms of narcolepsy. Narcolepsy is a chronic disorder caused by a reduction in a protein in the brain called orexin. There is strong evidence to suggest that narcolepsy is actually an autoimmune disease. Symptoms of narcolepsy. 1. Excessive daytime sleepiness, or EDS. At its core, this is what narcolepsy is, being tired all the time. EDS will continue even if a full night's rest is had. 2. Cataplexy. Cataplexy is loss of motor muscle control. You may experience sudden loss of motor control even while awake. This can be brought on with high emotions like crying. 3. Sleep paralysis. Sleep paralysis is a symptom where you are unable to physically move at the beginning and/or end of your sleep. 4. Automatic behavior. This is where you continue to function when you are asleep, and when you awaken, you have no memory of the event. 5. Microsleeps. A microsleep is when you go to sleep for a short time without warning and usually not recalling you were actually asleep. 6. Hypnagogic hallucinations. These hallucinations are vivid, dream experiences and can occur any time you are sleeping, dozing off, microsleeping, etc. 7. Quick entry into rapid eye movement, or REM sleep. Narcoleptics are unique in that they can enter REM sleep at the beginning of their sleep without having to wait the usual 90 minutes a normal person would take to enter REM sleep. 8. Nighttime wakefulness. It's almost an oxymoron that narcoleptics who are falling asleep all the time would have a problem with wakefulness, but in some cases you may have extreme periods of alertness at odd hours in the night. 9. Irregular brainwave rhythms. Normally, when you are awake, your brainwaves show a regular rhythm. However, narcoleptics often have irregular brainwaves due to entering and exiting sleep cycles spontaneously. Tips and tools to help you manage your narcolepsy. Narcolepsy is just one of the sleep disorders that people can suffer through. It is defined as the onset of a desire to fall asleep that the person cannot control. This condition can lead to the sufferer falling asleep in a situation that can be extremely dangerous and inappropriate. Can you imagine what it would be like if you were to fall asleep behind the wheel of a car? Think about all the people you would be putting in danger if that were to happen. Fortunately, there are a few different methods that you can use to help deal with the condition on a regular basis. 1. Take the time to schedule a nap in during the day. Something as simple as a 15 or 30-minute nap after your lunchtime and evening meal will help minimize the chances that you will fall asleep suddenly during the day. Schedule the time in to prevent any potential episodes when you least expect it. 2. Have a little bit of caffeine. Not everyone who has narcolepsy will benefit from caffeine, but there are a lot of times where the sufferer can find solace in a cup of coffee or tea. It will help to stimulate your body and prevent you from falling asleep during the day. 3. Consider using an antidepressant. Some narcoleptics will be able to benefit from SSRIs. They help to provide you with a sense of balance that helps limit the chance of being overwhelmed with the desire to fall asleep. 4. Ask your doctor about using a sleep aid. One of the biggest things for someone who is suffering with narcolepsy is that they may experience the urge to sleep during the day. However, when it comes time to go to bed at night, they end up suffering from not being able to sleep. As a result, they are not able to sleep when they need it the most, and because of this, they are even more tired during the daytime. If this is the case with your specific situation, you may want a prescription sleep aid to help you get the rest you need in the evening. This will allow you to get a full night of rest and wake up feeling refreshed and ready to tackle the day. You will not be as prone to falling asleep during the day because you will be getting the rest that you need during the evening. 5. Avoid any foods that could cause drowsiness throughout the day. Foods that are high in starches and carbohydrates can help to bring your body down and make you drowsy. When your body goes through the sudden burst in sugar, it will help the narcolepsy kick into gear and the sleep will come on without warning. As you limit your intake of these sugar-enriched foods, you will be helping to keep your body balanced and free from the chemicals that make you want to sleep. 6. Try to arrange your schedule to minimize the impact of narcolepsy kicking in. If you are someone who deals with outbreaks in the afternoon, you should try scheduling a meeting or an errand during the morning to prevent any interruptions or intrusions with your sleep patterns. Try to travel with a friend as much as you possibly can. This way, if you do tend to fall asleep, it will not put anyone at risk or in danger. The main idea is to try to take care of anything important when you are most likely to stay awake. Otherwise, you will never be able to get anything done, and it will be a never-ending cycle of trying to stay awake on top of the condition. Narcolepsy can be managed once you learn what you are doing to help control the condition. There is no reason why you should feel as if you are stuck sleeping all the time, because there is plenty that can be done to overcome the disorder and take control of your life. Enjoy all of the freedom you can have with narcolepsy when you learn what you can do to overcome the condition. Top herbal remedies for narcolepsy. Cayenne pepper. Capsicum minimum is the Latin name for this herb. Cayenne pepper is also known as Guinea spice or cowhorn pepper. It is named after a city in French Guiana called Cayenne. The fruit of this herb is crushed into a powder and used as a spice. This herb is also available in the form of tablets, tinctures, and ointments. Cayenne pepper improves digestion as well as circulation in the body. Due to this, it is very useful for making a person feel alert and active. Therefore, cayenne pepper is a good herbal remedy for warding off excessive sleepiness caused by narcolepsy. You can use cayenne pepper as a spice and also add it to hot drinks, soups, or gravies, and consume these to avail the benefits of this herb. Gotu kola. Gotu kola is a herb which has been used in Ayurveda for curing many maladies. This herb is a mild stimulant, and it is very good for activating and energizing a person suffering from narcolepsy. Gotu kola strengthens the functioning of the connective tissues in the body. This improves the strength of the veins and enhances the flow of blood and nutrients to the brain. Researchers believe that this changes the sleep patterns of the brain and improves a person's activity levels during the day. Gotu kola also oxygenates the brain. You can take this herb in an extract form for best results. Country mallow. Seta cordifolia, or flannel weed, is some of the other names by which this herb is also known. The seeds and roots of this herb are used to make various medicines. Country mallow contains ephedrine, which stimulates and activates the system. This helps to block the symptoms of narcolepsy, such as drowsiness during the day. You can use this herb to make tea, which you must drink regularly to fend off narcoleptic symptoms. Country mallow does bring about changes in blood pressure sometimes. Therefore, persons with cardiovascular conditions should only use this herb remedy after consulting a doctor and an herbalist. Ginkgo biloba. Ginkgo biloba is a herb which activates the nervous system and raises energy levels in people. This herb has been used extensively in traditional Chinese medicine for several diseases and health problems. Ginkgo biloba improves circulation in the body and helps in enhancing the supply of blood to the brain. It also contains antioxidants, which refresh and rejuvenate the body. Terpenoids and flavonoids found in this herb are very effective in healing a person who suffers from narcolepsy. You can take this herb in supplement form or as an extract. St. John's wort. Hypericum perforatum is the botanical name for this herb. This herb calms the nerves. It also enhances the quality of sleep in the night. A person suffering from narcolepsy enters deep sleep without going through the stages of light sleep first, and may experience difficulty in rousing during the day. But St. John's wort restores normal sleep patterns to people who have narcolepsy, according to some experts. St. John's wort can be taken in the form of an extract. You can also make tea using the dried form of this herb and drink it consistently to experience its beneficial effects. Rosemary. Rosmarinus officinalis is the botanical name by which this herb is also referred to. Rosemary is a popular culinary herb. It is also used to treat memory problems. However, this herb has yet another use. It can be used as a circulatory stimulant to make narcoleptic people alert and aware during the day. Rosemary contains camphor, which keeps the body and mind alert yet prevents overstimulation. Rosemary also improves the circulation in the body and prevents daytime drowsiness in persons diagnosed with narcolepsy. You can add dried rosemary to dishes, soups, and gravies, and have these for improving your wakefulness during the day if you suffer from narcolepsy. Asian ginseng. Panax ginseng, also known as Asian ginseng, is a herb which has innumerable benefits. One of the many uses of ginseng is to treat sleep disorders like narcolepsy. To overcome disturbed sleep patterns during the night and day, persons with narcolepsy can use Asian ginseng. You can take 2 to 3 cups of ginseng decoction daily. You can also take this herb in the form of an extract. Ginseng is also available in the form of a tincture. Asian ginseng, also known as Chinese ginseng or Korean ginseng, also improves circulation and blood flow to the brain, which enhances the ability of the person to overcome extreme sleepiness. Asian ginseng is also taken in the form of tea, capsules, and powder. Do not use this herb if you suffer from hypertension as well. Guarana. Paulina cupana is the Latin name for this herb. It contains xanthine alkaloids, such as caffeine, which improve the alertness and activity levels of persons diagnosed with narcolepsy. The seeds of this herb are used to make medication. This herb is also available in tincture and capsule form. Besides narcolepsy, this herb is also used for treating depression and mental fatigue. Guarana wards off the excessive sleepiness and tendency to drift off to sleep found in people who suffer from narcolepsy. This herb is also available in powder form. You can even roast the seeds in this herb and crush them to a fine powder. Consume this regularly to get the benefits of this herb. Those who have blood pressure problems must not take this herb remedy. Treating narcolepsy in children. Proper sleep is tremendously important for growing children. Without the proper dose of a good night's sleep, your child can suffer from various cognitive issues that can impact his academic endeavors. Most sleep disorders can easily be controlled with the help of proper diet and lifestyle changes. However, many other sleep ailments can become a headache for a lifetime if you are not careful in the beginning years. Fortunately, narcolepsy can be managed. What is narcolepsy? Narcolepsy is a sleep disorder that is characterized by excessive sleepiness that impacts the everyday life of a sufferer. The major symptoms of narcolepsy include constant sleepiness in the day hours, inability to maintain wakefulness, hypnagogic hallucinations, sleep paralysis, cataplexy, suddenly falling asleep during unusual hours and having no control over the sleep pattern. How do I know my child has it? Narcolepsy is quite easy to detect. If your child falls asleep on the breakfast table or fails to maintain wakefulness while playing around a school playground equipment in school, immediately get in touch with your healthcare specialist. Ask your child about his condition and see if he experiences any of the above-mentioned symptoms. Exercise in narcolepsy. There is no specific medication or treatment that will completely eliminate the signs of narcolepsy. A growing body of research shows that a child who is highly active with regular activity in outdoor playground equipment, or any playground for that matter, rarely develops narcolepsy. Your child's healthcare specialist might prescribe certain medications along with lifestyle changes. The most common medications for narcolepsy include dextroamphetamine or dexedrine, methylphenidate or Ritalin, and dextroamphetamine or Adderall, to name a few. What can you do? Sleep disorders are usually a result of improper diet and sleep. Children, unlike adults, require proper sleep to maintain their health, and lack of adequate sleep or irregular sleep patterns can impair their physical and cognitive growth. Here is a well-sorted list of things that you can do to prevent narcolepsy in your child. Maintain a regular sleep pattern of around 14 hours for toddlers and 10 to 12 hours for preschoolers. Avoid letting your kids devour junk food. Prepare a balanced diet and help your kids grow with natural foods and vitamins. Replace manufactured fruit juices with homemade fruit juices. Engage your kids with healthy physical activity. Whether it's church playground equipment or a backyard sandpit, any play area can help kids increase their chances of a healthy living, so let your child out in the playground. Understanding the importance of identifying narcolepsy symptoms. For many people, the struggle to stay awake when they need to is a daily battle. Narcolepsy affects about 1 in 2,000 people in the world, and it starts fairly early in life for those who have a genetic predisposition to the condition. Since humans vary greatly in brain makeup and susceptibility to environmental triggers, narcolepsy symptoms may vary greatly in severity between those who suffer from this condition. For most people, narcolepsy symptoms begin to appear between the ages of 10 and 25. Once the condition develops, it does not go away, even with treatment. Whether you are cooking, working, driving, or even enjoying a thrill ride, you can fall asleep. However, changes in lifestyle and new insights into medical treatments can help reduce the symptoms in order to allow you to live a full and active life. There are 2 primary symptoms. The first is excessive daytime sleepiness, and the other is abnormal REM sleep. This can result in sleep paralysis when you are unable to move or speak upon falling asleep or waking. Hallucinations, which can be visual or auditory and can sometimes be frightening, and especially cataplexy. This later symptom is a sudden loss of muscle control, often found with extreme emotions, and is unique to the condition of narcolepsy. Often this condition is hard to diagnose because many people complain of extreme tiredness during the day. but fail to realize that some of the other signs that signal they suffer from this condition. Medical professionals, therefore, must look for other symptoms, which many don't even know they have. One of the most unique features of this condition is what medical specialists call microsleep. These are very brief bouts of sleep where a person continues to function as if they were awake. They continue to talk, walk around, and put things away, but then have no memory of what they just did. Additionally, they often wake frequently at night when they experience an increased heart rate, hot flashes, and are sometimes so alert they cannot get back to sleep. When they do fall asleep, they enter REM sleep quite rapidly. For most people, this takes about 90 minutes. People with this condition will also have very vivid dreams or feel paralyzed at the beginning of their sleep cycle, even if it happens during the day. If you feel you may suffer from narcolepsy symptoms, it's important to seek a medical evaluation immediately, as continuing to function while asleep and having a disrupted sleep cycle can be extremely dangerous. What can I do to prevent getting narcolepsy? Essentially, those with this condition will end up falling asleep with no way to control it. This condition is normally the result of a genetic condition, and there is no known cure for the condition as of yet. However, you can take control of the condition by following some of the tips below to help regulate your sleeping patterns and overcome the condition. Take the time and consult with your physician about all of the different options available for counseling. Speaking with someone who has a specialty in sleep disorders will help you take control of your life and organize it. It will help you to avoid any narcoleptic fits and also help you on an emotional level to overcome this disorder that is trying to control your life. Speak to your doctor and ask them about medications for your condition. Stimulants work by keeping a lot of patients up during the daytime, but when it comes time to go to bed at night, they are not able to because the medication has not worn off. Antidepressants help to eliminate your REM sleep cycle. People who are suffering with narcolepsy can help prevent feeling tired during the day by using sodium oxybate. Make sure that you are scheduling regular times for sleep. Getting sleep on a consistent basis can help prevent narcolepsy. It is oftentimes the crazy sleep patterns that end up leading to narcolepsy in the first place. If you are able to go to bed at the same time on a regular basis and wake up at the same time every morning, you will be able to force your body into maintaining a proper sleep schedule. Regardless of whether or not it is during the week or the weekend, you need to maintain the same patterns throughout the duration to help regulate your sleep schedule. Don't forget about exercising. Exercise has been proven extremely beneficial to a lot of people who are suffering with narcolepsy. When you work out, it helps to put your body into a state of natural sleep and regulate your system. Just like you can take the time to follow a specific sleep schedule, you can take the time to make sure that you are exercising every day to eliminate feeling the effects of narcolepsy. Drink beverages that are good for you. Avoid anything that contains alcohol, caffeine, or nicotine. These three substances cause the body's natural cycle to get knocked for a loop, which can lead to some of the most erratic sleeping patterns out there. When you avoid the triggers, along with developing a consistent sleep and exercise routine, will help your body to avoid falling into the stages of narcolepsy. Just because you have been diagnosed with narcolepsy does not mean that you have to let it control your life. You can have the power to be able to take control of the condition by following a few simple tips and tricks to help you live a productive and engaging lifestyle. Take control of your condition once and for all with the proper changes in your life and health. In the end, you will find a lot of benefits with being able to go throughout the day without the fear of falling asleep right where you are. You can live a normal life free of narcolepsy if you only take the time to learn the proper maintenance techniques and make them part of your routine. Don't let the condition control you, but instead, it is time that you take control into your own hands.
Obsessive-compulsive disorder. How to overcome OCD. Written by Albert Rogers. Narrated by Lee Ashman. Introduction. Do you know what OCD is? Do you know what obsessive-compulsive disorder can cause? These are the questions you should ask yourself if someone near you or you is showing signs of this disorder. The problem is that a lot of people either think they have it when they don't, or they think they don't have it when they do. Clinical studies, signs, and symptoms are discussed in this book so you can find out where to draw the line and when to take action. Also, in this compilation of research reports and findings, I want to point out how to help solve the problem through medication, treatment, and psychological therapy. I assure you that you are looking at the right book for understanding, assessing, and handling obsessive-compulsive disorder, and that you will be amazed by some of the discoveries scientists and clinicians have made. Don't wait any longer and listen on. Chapter 1. What is OCD? Before we dive into any strategies or tips to deal with OCD, we need to establish what it is. Obsessive-compulsive disorder is often misunderstood. It's actually pretty common for people to be stuck in a habit they have a hard time breaking. Obsessive-compulsive disorder is an anxiety disorder in which people have unwanted and repeated thoughts, feelings, ideas, sensations, obsessions, or behaviors that make them feel driven to do something, compulsions. Often, the person performs the behavior to eliminate the obsessive ideas, but this only gives him or her temporary relief. Not carrying out these obsessive rituals can cause a lot of anxiety. A person's level of OCD can be anywhere from mild to severe, but if it is severe and doesn't get treated, it can obliterate someone's capacity to function. About 1 in 150 people suffer from this compulsive disorder. Eating disorders, depression, anxiety disorders, and other personality disorders can, in some cases, accompany OCD. The percentage of men and women who have this disorder is about the same. Usually, it already becomes apparent in someone's childhood, and research has pointed out that it is hereditary. Although these symptoms can be visible in one's childhood, studies indicate that most of the symptoms typically begin in the teen years. Treatment and testing are important when such symptoms are observed. As the words indicate, obsessive-compulsive disorder is a disorder that is based on obsessions, which come from fears and anxiety. As a response to these obsessions, an individual will typically perform rituals and repeat the same action over and over again, which is defined as compulsive behavior. The behavior, however, is only a visible result of the root problem. The root is the fears that cause the obsessive thoughts. In the next chapter, we'll elaborate on these obsessions and compulsive acts in more detail. Chapter 2. Symptoms. Which symptoms are typical for someone with obsessive-compulsive disorder? Here is a list of possible symptoms. 1. They have repeated thoughts or images in their heads about several things, like a fear of germs, intruders, hurting others, violence, sexual acts, or being overly neat. 2. They repeat the same behavior over and over again, like locking doors, washing hands, counting, or hoarding. 3. They constantly have undesired thoughts and behaviors that they find hard to control. 4. They do not find pleasure in the rituals or behaviors, but they find a short relief from anxiety if they perform them. 5. They spend an hour or more per day on these thoughts and rituals, which interfere with daily life. 6. Persistent, paranoid, often unrealistic fears. It's hard to reason with them concerning those aspects of their perception of reality. 7. Checking and washing are the most common reported compulsions of OCD. Others have a compulsive tendency to rearrange things, or mentally repeating phrases, or list-making. 8. Those with OCD often fear losing control. This doesn't mean that all control freaks have OCD, or that all people with OCD are control freaks, but the fear that they might harm someone with their compulsive behavior exists. 9. Religious obsessions occur, like the fear of offending God. 10. Unwanted sexual thoughts, like homosexuality or incest thoughts, could accompany OCD. This doesn't mean that the individuals should be considered a threat, homosexual, pedophilic, or uncontrolled, but it's typical for some with OCD to just have those thoughts bothering them. 11. Perfectionism is often typical to the point that they fret over exactness or a need to remember things or keep track of things. Some people with obsessive-compulsive disorder partially or fully understand the uselessness of their obsessiveness and compulsive behaviors, though they find it hard to stop doing it. Others lack a comprehension of their strange thinking patterns and are blinded to the fact that they are overdoing things. A lot of people with OCD are able to keep their obsessive-compulsive symptoms under control when they are working, studying, or feel relaxed enough to function well. Resistance might weaken occasionally, however, especially when they are anxious, when sudden changes in their lives occur, or when they panic inside. It's typical for symptoms to come and go, to become easier to handle or worse. If the symptoms become too terrible, their responsibilities and daily tasks may suffer from the consequences. Another way some people with OCD handle their obsessive-compulsive disorder is by taking alcohol or drugs, which obviously isn't a good solution at all. In the next few chapters, we'll research the disorder's origin in 3 different ways: biological, psychological, and environmental. Chapter 3. Biological Causes. The fact that OCD patients react well to particular medications affecting the neurotransmitter serotonin points out that the disorder has a neurobiological basis. The interaction of neurobiological factors, as well as cognitive processes, is the focus in this chapter. Coexisting disorders such as attention deficit disorder or autism can make OCD harder to diagnose and treat. The same is true when a person with OCD suffers from depression, substance abuse, or eating disorders. Symptoms of OCD are seen in association with some other neurological disorders. There is an increased rate of OCD in people with Tourette's syndrome, an illness characterized by involuntary movements and vocalizations. Investigators are currently studying the hypothesis that a genetic relationship exists between OCD and the tic disorders. Other illnesses that may be linked to OCD are trichotillomania, the repeated urge to pull out scalp hair, eyelashes, eyebrows, or other body hair, body dysmorphic disorder, excessive preoccupation with imaginary or exaggerated defects in appearance, and hypochondriasis, the fear of having, despite medical evaluation and reassurance, a serious disease. Researchers are investigating the place of OCD within a spectrum of disorders that may share certain biological or psychological bases. A common misconception is that people who are somewhat compulsive or perfectionists by nature can be classified as having OCD. Many people who show some compulsive or obsessive tendencies, which may be 90% of the population anyway, do not show extreme enough symptoms to be labeled as having a disorder in that sense. Moreover, try to see the value and contribution of being obsessed with a clean or orderly environment or the tendency to perfect things. How many companies could function without their precise accountants? How many surgeons would do a good job if hygiene wasn't one of their most important standards? And how many people would feel at home in a space where nothing was cleaned up or organized? Compulsive behaviors have their place in society, and some of them are highly needed. The problem with those who have OCD lies in the interference with essential rationale and crucial daily tasks. One person's story. One person with OCD said, "As far back as I can remember, my family and friends referred to me as a worrywart. When I was about the age of 16, my experiences with OCD began. I had just started high school, and things were stressful with all the changes. A friend of mine had been afflicted with a case of food poisoning, and that was when I acquired my fear of being poisoned. I can still remember how it started as a tiny concern and proceeded to snowball into the major preoccupation of my life." Brain science. OCD is actually caused by a combination of biological, psychological, and environmental components. As far as the biological aspects are concerned, a lack of serotonin, as I mentioned earlier, is the main cause. Serotonin sends neurological messages that transmit signals between brain cells. It plays a role in mood regulation, impulse control, aggression, appetite, sleep, pain, and body temperature. For example, after a visit to the bathroom, you may begin to wash your hands to remove any harmful germs you may have encountered. Once you have performed the appropriate behavior, in this case washing your hands, the impulse from this brain circuit diminishes and you stop washing your hands and go about your day. It has been suggested that if you have OCD, your brain has difficulty turning off or ignoring impulses from this circuit. This in turn means the obsessions and compulsions continue, leading you to wash your hands again and again. Studies concerning the various specific areas in the brain show that people with OCD show more unusual activity in 4 interconnected areas in the brain. 1. The caudate nucleus. 2. Specific brain cells in the basal ganglia. 3. The prefrontal orbital cortex. 4. The cingulate gyrus. The first, the caudate nucleus, is considered to be the main part of the brain that regulates repetitive and habitual behaviors. Medicine to treat OCD helps shrink the activity in this part of the brain. The last one, the basal ganglia, functions as a filter of thoughts entering the center of the brain from other areas. The prefrontal orbital cortex, located in the front area of the brain, is believed to make rational decisions and affect social behavior. In the brain of a person with OCD, there is too much activity lacking in this region. Often, the cause is that this region has been damaged because of biological or psychological occurrences and developments. A lack of guilt or responsibility is often a symptom of someone who is addicted and lacks activity in this part of the brain. The balance is off. Those who have become addicted, either to pornography, substances, eating, or gambling, have a smaller frontal cortex with not enough activity. In the brain of an addict, the frontal cortex is too small. However, in the brain of someone with OCD, there is too much brain activity in the frontal cortex. What does that mean? It means that they often become too worried, overly concerned, preoccupied, or left feeling too guilty or afraid to act appropriately. The last one, the cingulate gyrus, is located in the center of the brain, just like the basal ganglia. The cingulate gyrus contributes emotional responses to obsessive thoughts. The emotions connected to the compulsive behaviors are often what makes an OCD patient stuck in his or her patterns. This region of the brain is also highly interconnected with the prefrontal orbital cortex and the basal ganglia through various brain cell pathways. All of these neurological pathways and regions are highly affected by the levels of serotonin in the brain. For more about serotonin, take a look at 35 Tips for a Happy Brain: How to Boost Your Oxytocin, Dopamine, Endorphins, and Serotonin. Genetic causes. As with many disorders, OCD seems to run in the family. Approximately 50% of all cases with OCD show this pattern. If someone has a family history with this disorder, he or she is more likely to have it, as well as siblings, parents, or children. Studies have fought the presumption that family members teach OCD to each other based on the observation that individual family members typically have different symptoms of OCD. Researchers have failed to find specific genes that cause OCD, so in this sense, the genetic roots are still somewhat of a mystery to many clinicians. There have, however, been a lot of discoveries regarding the regulating of serotonin. Studies on twins have indicated that if one twin has OCD, the other has more of a tendency to have the same disorder. Nerve cells. The task of your nerve cells is to send messages and interconnected impulses, kind of like a telephone wire. However, nerves aren't a single string. The cells are all linked to each other. It's like the game of telephone, where a person whispers something in someone's ear, who whispers it to the next, etc. In time, the message changes, and sometimes it completely deviates from what the original message was supposed to be. This is how the brain works as well. The messages and impulses go through a series of processes and regions, which divert the original message and turn it into a somewhat different interpretation. How different that interpretation is depends on the person, how well the cells work, and on how healthy and undamaged those neurotransmitters inside a person's skull are. One nerve cell sends a message to another, and that one sends the message to another, and each time a nerve cell receives a message, a chemical gets released. Often, these chemicals are serotonin. An important gene in this process is hCERT, which makes serotonin transporters. Sometimes, when a person has OCD, the hCERT gene works too quickly, which causes the cell to collect all the serotonin before the next cell has even received the signal. OCD patients' nerves are whispering when they should be yelling. Another cause of the disorder, according to research, might be the membrane protein responsible for the reuptake of serotonin from the synapse between the neurons. This transporter protein is bound by serotonin inhibitors, or SSRIs, which block the transporter's function and leave more serotonin available for neuronal communication within the synapse. The researchers found a mutation inside the hCERT gene, which they categorized 1425V. The mutation seems to be associated with an extended expression of the hCERT gene, resulting in extra transporter proteins appearing inside the neuron's membrane. This results in accelerated reuptake of serotonin in those neuronal synapses, lowering the amount of serotonin available inside the synapse for signaling. The second mutation diagnosed, a long allele of the promoter portion of the serotonin transporter gene, 5-HTT-LPR, outcomes in comparable cellular effects, an increase in transporter proteins leading to a decrease in serotonin being available for neuronal conversation. The two mutations performing together bring about a notably lower quality of serotonin available within the synapse that is visible with either one of the mutations alone, resulting in extra biochemical consequences and more extreme signs and symptoms. Other research has shown that there can be some other elements that would play a role inside the onset of OCD, such as behavioral, cognitive, and environmental elements. Research has found out a terrific deal about the psychological factors that preserve OCD, which in turn has brought about effective psychological treatment within the shape of cognitive behavioral therapy, CBT. For instance, according to the learning theory, OCD signs and symptoms are a result of someone developing learned negative thoughts and behavior styles in the direction of formerly impartial conditions which can result from life studies. Many cognitive theorists believe that people with OCD have defective beliefs, and that it is their misinterpretation of intrusive thoughts that leads to OCD. According to the cognitive model of OCD, all of us experience intrusive thoughts from time to time. However, human beings with OCD frequently have an inflated experience of duty and misread these thoughts as being very vital and full size that could result in catastrophic outcomes. The repeated misinterpretation of intrusive thoughts results in the development of the obsessions, and because the thoughts are so distressing, the man or woman engages in compulsive behavior to try and resist, block, or neutralize the obsessive thoughts. A few researchers trust that this theory questions the biological theory because humans can be born with a biological predisposition to OCD, but in no way develop the full ailment, while others are born with the same predisposition but, when subject to enough learning experiences, develop OCD. Scientists have observed that another gene, known as SLC1A1, is probably involved. This gene is similar to hCERT, but is in charge of absorbing a different neurotransmitter, referred to as glutamate. Chapter 4. Psychological Causes. Many psychological theories have been delivered to give an explanation for the improvement of OCD. The two that have received the greatest support are the behavioral and cognitive theories. Behavioral theory. The behavioral theory indicates that humans with OCD associate certain objects or situations with fear, and that they discover ways to avoid the things they worry about or to perform rituals that help lessen the concern. This pattern of worrying and avoidance/ritual can also start whilst people are under periods of excessive emotional pressure, along with beginning a brand new process or ending a relationship. At such times, we are more susceptible to fear and tension. Often, matters once regarded as neutral might also begin to bring about feelings of worry. For example, someone who has always been able to use public bathrooms may, when under pressure, make a connection between the restroom seat and a fear of catching an infection. Once a connection between an item and the sensation of worry becomes installed, human beings with OCD avoid the matters they fear, as opposed to confronting or tolerating the fear. For instance, the individual that fears catching an infection from public bathrooms will avoid using them. When compelled to use a public bathroom, he or she will be able to carry out problematic cleansing rituals, which include cleaning the restroom seat, cleansing the door handles of the cubicle, or following a detailed washing procedure. Because those actions quickly reduce the level of fear, the concern is never challenged and treated, and the behavior is reinforced. The association of worry may additionally spread to other objects, which includes public sinks and showers. In behavioral therapy, people with OCD discover ways to confront and decrease their anxiety without working towards avoidance or ritual behavior. After they learn how to directly confront their fears, they become less afraid. Cognitive theory. While the behavioral theory specializes how humans with OCD make an association between an item and fear, the cognitive theory focuses on how humans with OCD misread their thoughts. Most people have intrusive or uninvited thoughts, much like the ones pronounced by way of human beings with OCD. As an instance, parents under pressure from caring for an infant can also have an intrusive notion of harming the infant. Most people might be able to shrug off this type of idea. People liable to developing OCD, however, might exaggerate the significance of the concept and respond as though it represents an actual threat. They will think, I must be a risk to youngsters if I have thoughts of harming kids. This could cause a high level of hysteria and other bad emotions along with disgrace, guilt, and disgust. Those who come to fear their personal thoughts normally try to neutralize feelings that arise from their thoughts. One way this is done is by means of avoiding conditions that might spark such thoughts. Another way is through carrying out rituals along with washing or praying. Cognitive theory suggests that as long as human beings interpret intrusive thoughts as catastrophic, and as long as they continue to believe that such thinking holds truth, they may continue to be distressed and to exercise avoidance and/or ritual behaviors. In line with the cognitive theory, individuals who connect exaggerated risk to their thoughts do so because of fake ideals learned earlier in life. Researchers assume the following beliefs may be critical within the development and protection of obsessions. 1. Exaggerated responsibility, or the belief that one is responsible for stopping misfortunes or damage to others. 2. The notion that positive thoughts are very critical and should be managed. 3. The belief that somehow having a thought or an urge to do something will increase the possibilities that it will come true. 4. The tendency to overestimate the likelihood of danger. 5. The perception that one must always be ideal and that errors are unacceptable. One person's story. After I first experienced my OCD, I thought I was losing my mind. I had by no means worried about those ideas before, and now I was completely enveloped by them. I knew what I used to be feeling became unreasonable, but I still had this terrifying feeling of what if. What if it was at all viable for this stuff to happen? I knew that the odds were 0.0001%, but I would still be overwhelmed with the worry that something disastrous would possibly occur to me or someone else. In cognitive therapy, people unlearn their incorrect beliefs and exchange their styles of thought. Through doing so, they're able to get rid of the misery associated with such thoughts and to stop their compulsive behaviors. No person really knows what different factors might be concerned. Perhaps an illness or maybe normal life stresses should result in the activity of genes associated with the symptoms of OCD. Generally accepted in the past, but those days increasingly more left out, the psychoanalytic theory shows that OCD develops because of a person's fixation springing up from unconscious conflicts or pain they experienced during infancy or youth. This theory is now pretty rightly overlooked because of the failure of psychoanalytic therapy to treat OCD. Major stresses or annoying life activities may also precipitate the onset of OCD. However, those aren't thought to cause the OCD, but rather trigger it in someone already predisposed to the disorder. Depression is also every so often thought to cause OCD, despite the fact that the general opinion is divided, with the majority of experts believing that depression is usually a symptom of OCD rather than a cause. There is nevertheless a great deal of theoretical contention surrounding the definitive cause of OCD, but all of the above theories provide compelling and highly informative insights, with the possibility that a mixture of the theories may also eventually be diagnosed as the real cause of OCD. Whilst the cause is presently still being debated, sometimes vigorously by the scientists, what isn't always in competition is the reality that obsessive-compulsive disorder is indeed a continual, but equally a very treatable medical condition. Chapter 5. Environmental Causes. Environmental stressors may be a cause for OCD in individuals. Let's take a look at some of these stressors. Brain injuries in teens and children have also been related to an increased risk of a continuing obsessive-compulsive disorder, with one study finding that 30% of kids aged 6 to 18 who experienced a brain injury showed signs of OCD within 12 months of the damage. Usually, research suggests that sufferers with OCD often report traumatic and difficult life circumstances before the disorder begins. Tension and parenting patterns are environmental elements that have been blamed for inflicting OCD, but no evidence is there yet to that claim. Sure, these factors could contribute to the development of it, and the right environment for an OCD patient certainly determines how strongly the symptoms appear, but to say that the environment or a person's childhood by itself are the main roots of obsessive-compulsive disorder is a false notion that cannot be proved. Pressure does not cause OCD, despite the fact that a worrying event may also trigger its onset. If left untreated, regular anxiety and pressure in a person's life will worsen signs and symptoms of OCD. Issues at school or paintings, college exam pressures, and ordinary problems in relationships can all bring contributory factors to growing the frequency and severity of someone's OCD behavior. Several youngsters begin to show off signs after an extreme infection, which could be something like strep throat. The frame's natural response to infection, the production of sure antibodies, though directed to components of the mind, might be related in some manner to pediatric autoimmune neuropsychiatric problems associated with streptococcal contamination, PANDAS. Research found that the infection doesn't mainly cause OCD, but it triggers signs and symptoms in kids who are genetically predisposed to the disorder. It's a fair notion that if OCD is caused by a form of strep throat, the symptoms will start speedily, in all likelihood within 1 or 2 weeks. Chapter 6. Solutions. In this chapter, we'll discuss a few solutions, and in a later chapter, we'll go more in depth when it comes to certain treatments for OCD. Left untreated, OCD usually develops into a chronic condition with episodes where symptoms seem to improve. Treatment for OCD will depend upon how a lot of the situations affect the patient's ability to function. Best treatments. First-line treatments for OCD will regularly include 1. CBT, cognitive behavioral therapy, 2. SSRI, selective serotonin reuptake inhibitors, 3. Combination of SSRI plus CBT, 4. Cognitive behavioral therapy. CBT is a powerful method for treating OCD. CBT is a kind of psychotherapy, talking therapy, that tries to help the patient change the manner they believe, feel, and behave, and refers to 2 tremendous remedies. A. Exposure and response prevention, ERP. B. Cognitive therapy. Studies have shown that 75% of human beings with OCD are significantly helped through cognitive behavioral therapy. Exposure and reaction prevention, ERP. Exposure. A part of this remedy entails exposure to conditions and objects that cause fear and anxiety. Over the years, the tension generated through these obsessional signals decreases, and, subsequently, the obsessional signals cause little or no anxiety. Reaction. Response prevention refers to the ritual behaviors that people with OCD have interaction in to reduce tension. This treatment enables patients to learn how to face up to the compulsion to carry out those rituals. Chapter 7. More bonus tips. Here are some tips for handling OCD, just to line them up. 1. Continually count on surprises. You can have an obsessive thought at any time or in any vicinity. Don't be surprised if some new ones occur. Don't allow it to upset you. 2. Be inclined to just accept hazards. Danger is an imperative part of life, and as such, it can't be completely eliminated or ignored. Take into account that not recovering is the biggest hazard of all. 3. Don't waste time seeking to save yourself. This may only have the opposite effect and result in having worse thoughts. Studies have indicated that you cannot successfully prevent or suppress thoughts, so accept that. But a thought is a thought, nothing more. 4. Don't get impatient with your progress. Don't compare yourself to other people. Everybody has their own pace. Just concentrate on doing your therapy homework every day, one day at a time. 5. Face the anxiety. Don't shy away and try to evade it. The best way to overcome fear is to realize it is there. You cannot turn off your thoughts, so just face them. It is the only road to recovery. Choose the harder one when confronted with 2 choices. 6. Look at your homework from therapy each day. It's easy to overlook your tasks, especially the ones you don't want to do. 7. Let your therapist know about assignments that are too hard for you. If you can't do it, then don't. You're not ready yet, and that's okay. The homework they give you isn't supposed to overwhelm you, but help you. 8. Don't procrastinate therapy. There is no perfect moment. The perfect moment is simply when you start taking action. Perfectionism is something you are trying to avoid anyway, because it lies at the root of obsessive-compulsive disorder. Don't be too hard on yourself, and just do what you can. Don't do your homework so excessively that it takes up too much of your time. Living life to the fullest is the purpose. So get rid of that tunnel vision towards your goal for a little bit and enjoy the fun in your everyday life. 9. Believe in the homework you've been given. Don't brush it aside and only do it because you were asked to. If you don't trust your therapist, then what's the point? Look, these trained professionals often know exactly what they are doing and what you are supposed to do to overcome or handle your disorder. So take their word for it and put your heart and soul into your assignments. 10. It's okay to feel anxiety. In time, it will decrease if you keep doing what you should be doing. So don't freak out about freaking out. Don't get angry because you're angry. And don't get stressed because you are and you shouldn't be. I've been in those circles myself, and it's not worth it. 11. Don't forget that you still have OCD. That means you cannot always trust your own feelings or reactions because your brain has been wired to think in extremes. If you don't know for sure if something is a symptom, then treat it as one. It's better to do a little more than not enough. 12. Remember that compulsions are the problem, not anxiety. If you recognize this, you will stop the compulsions and stay with the fearful situation. Eventually, the anxiety will go away as you boost your tolerance levels. 13. Reward yourself. It doesn't have to be a physical reward. It can just be patting yourself on the back or being proud of yourself. Look back at the recent assignments that are no longer difficult if you think you weren't making enough progress. 14. Keep in mind that OCD is paradoxical and doesn't always add up. It doesn't make sense what you feel all the time. Some things appear to be worse than they are, so don't freak out and relax as much as you are capable of. Chapter 8. Medicine, Counseling, and Treatment. Let's talk about some solutions to the disorder. First, let's continue with medicine, since I already mentioned some facts about this. Medicine. Restorative medications named particular serotonin reuptake inhibitors, SSRIs, are often utilized to handle obsessive-compulsive disorder, even though it isn't entirely perceived why the SSRI solutions appear to help a couple of people with OCD. There is a certain medication that backs off OCD by collecting serotonin via transporters such as hCERT, which points out that serotonin stays inside the range between the cells longer and increases the odds that the second versatile receives the message, which spares you some OCD signs and side effects. Therapy. Clinical trials recently have demonstrated that medications that influence the neurotransmitter serotonin can overall diminish the manifestations of OCD. The first of these serotonin reuptake inhibitors, SRIs, particularly affirmed for the utilization in the treatment of OCD was the tricyclic upper clomipramine, Anfranil. It was trailed by different SRIs that are called particular serotonin reuptake inhibitors, SSRIs. Those that have been affirmed by the Sustenance and Medication Organization for the treatment of OCD are citalopram, Celexa, fluoxetine, Prozac, fluvoxamine, Luvox, paroxetine, Paxil, and sertraline, Zoloft. Expansive reviews have verified that more than 75 out of 100 patients are aided by these pharmaceuticals. What's more, in most patients, solutions alleviate side effects of OCD by decreasing the recurrence and power of the fixations and impulses. For patients who are just in part receptive to these medicines, research is being directed on the utilization of a SRI as the essential pharmaceutical and one of an assortment of prescriptions as an extra medication, an augmenter. Drugs are of assistance in controlling the side effects of OCD. Conduct treatment. Psychological behavioral treatment, CBT, has appeared to be the best sort of psychotherapy for this issue. The patient is presented to a circumstance that triggers the over-the-top symptoms and adapts step by step to endure the tension and fight the temptation to play out the impulse. Prescription and CBT together are thought to be superior to treatment alone at decreasing side effects. Certain approaches demand that the patient intentionally and deliberately stands up to the dreaded protest or thought, either specifically or by creative ability. In the meantime, the patient is unequivocally urged to forego ritualizing, with support and structure given by the specialist, and perhaps by others whom the patient volunteers for help. Treatment, then, continues on a well-ordered premise, guided by the patient's capacity to endure the uneasiness and control the ceremonies. As treatment advances, most patients gradually encounter less anxiety from their excessive thought patterns and can oppose their impulsive inclinations. Psychotherapy can likewise be utilized to provide powerful methods for lessening stress, tension, and settling inward clashes. Approaches to make treatment more successful. Stretch administration systems and contemplation can help individuals with anxiety problems calm themselves, and so they may upgrade the impacts of treatment. There is evidence that vigorous practice may have a quieting impact. Since caffeine, certain illegal medications, and even some other pharmaceuticals can disturb the signs of anxiety problems, they ought to be kept away from them. In other words, don't do drugs or any medication the doctors haven't prescribed, and don't use caffeine. Check with your doctor or drug specialist before taking any extra medications. Family. The family is essential in the recuperation of someone with an uneasiness issue. In a perfect world, the family ought to be strong, but not help sustain their cherished one's side effects. Relatives ought not to trivialize the turmoil or request change without treatment. At that point, when a relative experience happens, it's useful to be understanding about their advance and recognize any triumphs. When a family is supportive of an individual with OCD and shows respect and empathy, patients will be less anxious and better able to handle the effects of their disorder. Although this is obvious, reality shows that many family members underestimate the impact they can have. This has been Obsessive Compulsive Disorder: How to Overcome OCD, written by Albert Rogers, narrated by Lee Ashman. Copyright 2017 by Albert Rogers. Production copyright 2017 by Albert Rogers.